Whenever I have time, I always
सुरेखा
join.
तुम्हारी लाइट पीछे से आ रही है.
You have a glare on the left side.
Dr. Deepa, if you can get your face illuminated, it'll be better.
Jayam, you will be staying till last now, or you will be logging out?
Hi,
Hello,
Lakshmi.
Vijayalakshmi.
Today is the 8th birthday of my Baba temple.
Okay, so what time?
By
Hi,
5:50,
Lakshmi.
I
Good
let
evening,
go for
madam.
the Aarati.
Hello.
Okay.
Hi, Lakshmi.
Hi.
Otherwise, I can stay.
बस अभी घर ही जा रही हूँ मैं हॉस्पिटल से. I will join from there.
Double Lakshmi join हुई. Hello.
First lecture is by Nutan Mishra only. No, second lecture is by Nutan.
Okay.
Okay.
Yeah. Bye.
Lakshmi,
Actually, we had about 800 for HIV conference. This time 8,000.
Lakshmi ma'am, it's 4:30 now. Can we start?
Yeah, we will start.
Yeah, please.
Okay. So a very warm good evening to all respected panelists and delegates.
Jayam, you will be staying till last now, or you will be logging out?
I'll be logging out for about 40 minutes in between.
Yeah.
Ma'am,
Okay, so what time? Please mute. Yeah, everyone here.
ma'am, we are starting.
Okay.
Hi, Lakshmi.
Hi.
बस अभी घर ही जा रही हूँ मैं हॉस्पिटल से. I will join from there.
Double Lakshmi join हुई. Hello.
Okay, ma'am.
Why there's a echo of previous talks?
Lakshmi ma'am, we are starting the webinar. So a very warm 4:30 now. Can we start?
We will start.
A very warm good evening to all respected panelists and delegates. This is Feroz Khan from Team Walter Bushnell. We welcome you all to this Indo-International Web Series 10 in association with RCOG Indian Legion, also known as RILG, presenting a live webinar on Theme-Obstetrics Drill Part 1. So we look forward to a wonderful knowledge exchange event today. So without any further delay, I would like to call upon Dr. Jyoti Malik ma'am, who is the Medical Superintendent, JJ Institute of Medical Sciences, Bahadurgarh. So to take this scientific session ahead, over to you, respected Jyoti Malik ma'am.
Yeah, thank you so much. Thank you, Walter Bushnell. Thank you, Mr. Feroz Khan. And welcome all the speakers, all the faculty, all my international faculty specifically, because you have really made an effort to join on this Saturday morning at your place. And specifically are all the participants who have joined us on this very, very important topic. And since we are missing our international coordinator, Dr. Jyotsna Pundir, who is a specialist at in infertility and assisted conception at London, she is our international coordinator. And though she would not be able to join today for some reason, but I would like to thank her from the core of my heart, because on the international part, she is the one who has been arranging us all these gems. All the gems that we have here on the screen today, they are being given by Dr. Jyotsna, and she manages the India Liaison Group at RCOGN. So thank you so much, Dr. Jyotsna. And the next person, the convener, I would like Dr. Lakshmi. I would thank her from bottom of my heart to collect the Indian gems here on this platform. So Dr. Lakshmi, as we all know, I would like her CV to be displayed, please. So Dr. Lakshmi Sri Khande ma'am is a consultant at Sri Khande Hospital Research Center, and she is chairperson elect ICOG. She is national corresponding editor journal Jogi. She is national corresponding secretary Association of Medical Women India. And since she has asked me to keep it very short, yes, I would like you to go through it very fast, because
no, don't do it.
So it is really, I mean, everybody knows her, so we will just skip that CV yes. now. So, and I would also invite Dr. Lakshmi to say a few words before I introduce my national convener for today, Dr. Nutan Mishra.
Yes, thank you. Thank you so much, Jyoti. I know this is all your brainchild. one day Jyoti just phoned me that we should start a Indo-International series, and see, today we are having the 10th webinar of that series. So I'm so happy that you conceived and Jyotsna pitched in. Then I just called Jyotsna and she said, yes, why not? Let us have this series. And I'm so happy that we are having James from London, RILG, and from our Indian side, and it is the mutual exchange of knowledge between both the RILG and Indian counterparts. So I'm so happy to welcome Dr. Nutan, Dr. Deepa, missing Jyotsna Pundir here, Dr. Jayam, Dr. Abha, our moderators, Dr. Mitra, Dr. Surekha, and I also welcome Supriya, Dr. Sheila Mane, Dr. Varsha Vaste, our eminent panelist, Dr. Mala Srivastav, Vijay Lakshmi, Dr. Abha Rani, and Dr. Maushmi Tadas. And I also welcome all the dear participants who have logged in. So without wasting much time, I hand over back to Jyoti to start with the scientific deliberations, as this webinar is on the theme of obstetric drill part 1, and we are covering shoulder dystocia and maternal collapse. And you all will agree with me that both these conditions are responsible for increased maternal and neonatal morbidity and mortality. So let us hear from the experts how we all can contribute towards reduction of these morbidities and mortalities. So Jyoti, please start with the sessions.
Sure, ma'am. Thank you so much for your kind words, ma'am.
One second, Jyoti. One second, Jyoti. Please get Dr. Mala upgraded.
Yeah, we will.
Yeah, so can we start with our first topic of maternal collapse? And for to chair this very important session, we have Dr. Jayam Kanan, ma'am, Emeritus Professor, Tamil Nadu MGR Medical University, Director GFC Fertility Center, Trichy and Chennai. And everybody knows, ma'am, she is such a senior person, such an academic personality. Anybody who has been an obstetrician and gynecologist of India should be has seen her at many platforms. So welcome to ma'am on this webinar today. And our second chairperson is Dr. Supriya Jaiswal. She is Secretary of Patna OBGY Society. She is chairperson-elect now. She'll be doing a lot of work, and we'll be seeing her a lot doing adolescent health promotional activities in her tenure from 2023 to 25. And she has been an executive member of many chapters, ISAR, Bihar chapter, IAGE, and many others. So over to Dr. Supriya now to introduce our first international speaker, Dr. Nutan Mishra.
Thank you, Dr. Jyoti. At the outset, a very good evening to everyone. And I bring greetings to you all from Team Patna OBGY Society. And thank you very much, Dr. Lakshmi Srikhande, madam, for always having me here. Thank you very much. And thank you, Dr. Jyoti Malik and all the organizers, Mitra, madam, Dr. Abharani, and all the faculties present here. Thank you very much, and nice meeting everyone. Just to formally introduce Dr. Nutan Mishra, she is currently working as a consultant in obstetrics and gynecology for the last 9 years at Bucks Healthcare, NHS.
Dalu, your speaker is not working. Kar raha hai.
Mine. Is it me? Can you hear me? No,
it's clear. It's clear.
Okay.
Yeah, please go ahead, Supriya.
Then my her main interest is in high-risk pregnancy, particularly pre-eclampsia, growth restriction, diabetes, and perinatal mental health. She is very much passionate about antenatal care and childbirth, and she is actively involved in teaching and training, and also an accredited colposcopist. She is an examiner for Part 3 MRCOG and also OSCE examiner for Oxford medical students. She is a felicitator for Basic Surgical Skill course, MRCOG Part 3, OSCE course. Then she regularly teaches CTG and obstetric emergencies in her department, and obstetric lead for clinical governance. She has also written books, chapters on PPH and rupture of uterus. Voluntarily, she facilitated the course of basic emergency and obstetric care newborn care run by Liverpool School of Tropical Medicine. So she has a very huge CV and madam has been doing lots of work. So over to you, madam, for your deliberation.
Thank you, everybody. Firstly, thank you for inviting me and giving me this opportunity to share some of my thoughts. So I'm going to just share my screen and hopefully we've tested. It should work. Just give me a moment. Sorry, I can't get to the slideshow button for some reason.
Or you can click there from beginning. Yeah.
Yeah, that's fine. So hopefully you should see the screen now.
Yeah. We can.
Okay, so I'm going to talk about maternal collapse. So maternal collapse is rare, but it is a very life-threatening event. And in the UK, not every obstetrician will see a maternal collapse in their career. And hence it is even more fearful because we don't see it that often. But, in your lifetime, maybe you'll be faced by this. So it's caused by acute cardiovascular, respiratory, or central nervous system failure, which occurs at any stage of pregnancy. And it can be up to 6 weeks postpartum. Generally, this will lead to cardiac arrest or death if it is unsuccessfully treated. Hence, the importance of its treatment, mainly preparedness, because if you're not prepared because it happens suddenly, and the quick action is very vital. And then on addition, physiological changes in pregnancy, we know that there's a lot of physiological changes that happen in pregnancy, and that can accelerate the development of hypoxia and acidosis, and that makes ventilation even more difficult. And combined with not only the physiological changes, you then have some physical changes in pregnancy as well, which then makes resuscitation during pregnancy more challenging. So firstly, you're already fearful of the situation, and then you have a big challenge to face as well. And then the other challenge is treating the mother and the baby simultaneously, while our priority will always be the mother. So that's why it's very vital that every maternity healthcare provider is familiar with the management of maternal collapse, because we know that adequate and timely intervention has a direct impact on the outcome. And that's why, I mean, recently I did the training with our A&E doctors, just because, it can happen in, mostly it happens in the emergency and accident department. So they all should be at least be versed with the principles of maternal resuscitation. As we said, it can be a bit difficult. So there are many causes of sudden collapse. Some are, obviously related to the pregnancy itself. So like we talked about hemorrhage, eclampsia, abruption, uterine rupture, amniotic fluid embolism, anesthetic complications. But we shouldn't forget that, not all, is pregnancy related. And sometimes, anything a pregnant woman comes, we forget about things that are outside pregnancy. So pulmonary embolism, sepsis, epilepsy, myocardial infarction, hypoglycemia, and the end, the list goes on. There are some reversible causes of cardiac arrest, as we said, before, they will have a cardiac arrest before they die, which are the 4 T's and the 4 H, which everybody is well versed, but I'll just go over that again. So that's like your hypovolemia, your hypoxia, your hyperkalemia, and hypo and hyperkalemia. And similarly, the 4 T's, just for a reminder, is thromboembolism, any drug toxicity, your cardiac tamponade, and your tension pneumothorax. And that's why, because this can be sudden, we don't know the cause, we have to have a very systematic approach when we're looking at the causes of maternal collapse. So, as we discussed, understanding physiological changes is, very is important for effective sort of management. There's a rapidly enlarging uterus, which has a very rich vascular supply, and along with the hormonal changes, this drives the adaptation process in the, on basically all the systems. So it's your cardiovascular, your hematological, your gastrointestinal system. And then these changes are upregulated by the prostaglandins, progesterone, and the estradiol. So it doesn't make it easy. And then there's peripheral vasodilation, which is like your key to maternal adaptation, basically to pregnancy. So it's helping us to cope with the pregnancy, but that results in a decrease in the systemic vascular resistance, and that doesn't help us when we are in trouble. So we've got this big enlarging uterus, which is causing aortic cable compression after 20 weeks onwards, and that will cause a decrease in our cardiac output and the efficacy of cardiac compressions during resuscitation. This also, this gravid uterus also decreases the venous return when we are in supine position, and also the cardiac output is decreased by about 30 to 40%. Now, normally in an arrest, when we are giving chest compression in a non-pregnant situation, we are only providing like 30% of their sort of cardiac output. And because if we have aortocaval compression because of pregnancy, this is reduced further by about 10%. So therefore, our CPR is not going to be effective after 20 weeks of pregnant. And it might be that, I'm repeating some of these things more, but I think for me, those are the important points. Because, if I go into other things, I think all of us know that. So it's just stressing the importance of, so if I do apologize in advance if I've repeated myself a few times. So difficult intubation is more likely in pregnancy, and that's because there's a lot of weight gain in pregnancy. Then there's large breasts as well, which is inhibiting our working space. And then the laryngeal edema that we have. So, nothing is helping us. Then there are changes in lung function, diaphragmatic splinting, and increased oxygen consumption because there's a baby as well. So the pregnant woman becomes hypoxic very readily. And then there's risk of aspiration in pregnancy. So there's risk of regurgitation and aspiration. And as we all know that the progesterone effect of relaxing the lower esophageal sphincter raised then, on addition, the raised intra-abdominal pressure secondary to this big uterus. And then there's delays gastric emptying, firstly because of the labor, sometimes the maternal opioid administration. And we know that aspiration pneumonitis in pregnancy can be severe. Now, these risks can be minimized by firstly early intubation. If we need to do early intubation with effective cricoid pressure. And then the H2 antagonist and antacid prophylaxis in all women who are considered to be high risk of obstetric intervention in labor. And we do give these in labor if we think, they will need a cesarean section or anything in the near future. Now, we know that maternal collapse can always not be predictable, and it is sudden. But cardiac arrest can sometimes be forewarned. So if you use a validated obstetric early warning system when you're caring for ill patients, and these are known as the Meows chart, where you're sort of putting all your observations on a regular basis, that gives you a trend, and that also shows you if, and always before cardiac arrest and all, we've seen that there will be some warning signs, which we sort of have not picked up. There's also and if we use a systematic, as we said, ABCD approach to treat the pregnant patients, then we might prevent this. Again, placing the patient in left lateral position, either manually or generally displacing the uterus, and that on to the left, and that's to relieve your aortocaval compression. And we talked about, pregnant ladies getting hypoxic very quickly, so giving oxygen, and that can be guided by pulse oximetry and correct hypoxia. But as a rule of thumb, if there's a pregnant lady, give her oxygen, give it to the full, give her 14 liters of oxygen. You're not going to do any harm in that. Again, other things that we can do to prevent is give fluid bolus if they are hypo hypoperfused or hypovolemic. But obviously, some pregnancy-specific conditions like eclampsia and preeclampsia, you have to be careful. But yes, giving a fluid bolus is not going to harm. And then re-evaluate the need for any drugs that you've given. So say, there's a magnesium sulfate toxicity or something that is causing the lady to rest, then yes, that's an early multidisciplinary input. So obstetric, anesthetic, critical care, and neonatology's involvement is the key. And then identify and treat the underlying causes of cardiac arrest. So if there's blood bleeding, then control your blood pressure, sepsis, early, that golden hour of giving fluids, antibiotics is quite important. And then we tend to forget tranexamic acid. Even in the UK, we don't, sometimes I have to be reminded by my anesthetic colleagues to say, do you need tranexamic acid? But it is, important to give tranexamic acid 1 gram IV if there is for postpartum hemorrhage or there's any bleeding. So we talked about the prevention. Now I'm just going to talk a little bit about the modification of advanced life support, which is applicable in pregnant patients. So there are, if I have to give you the message, there are only 3 things. So one is early intubation, if we need to, tilting the patient to decrease aortocaval compression, and the third thing is emptying the uterus. So if the patient is more than 20 weeks, or if you don't know how many weeks gestation she is and the uterus is felt above the umbilicus, then we need to relieve that aortocaval compression. And the way you can do it is either manually displace the uterus to the left to relieve the aortocaval compression. If feasible, you can add a left lateral tilt, but the chest should remain supported on a firm surface because you have to do the compressions. And the optimal angle is still not known, but the aim for the tilt is between 50 to 30 degrees. But even a little bit tilt is better than, putting no tilt. And the angle of tilt needs to enable a high quality chest compression and if needed, surgical delivery of the baby. So prepare for emergency cesarean. If they're more than 20 weeks pregnant and the uterus is palpable above the umbilicus, then if immediate resuscitation is unsuccessful, then within 4 minutes. And delivery of the fetus in emergency cesarean aiming for delivery in 5 minutes. I recently saw a paper in one of the journals, which I can't remember, where they said even this 4-minute rule, is not valid. You have to deliver as quickly as possible within minutes. Now, if we need to, if we have to place defibrillator pads, they should be placed in, as far as in position as far as possible. And we use the same standard shock energies, and it's no different for a non-pregnant patient. So the rationale for evacuation of the uterus within 5 minutes by perimortem cesarean section, because a pregnant woman becomes hypoxic more rapidly than non-pregnant women, and the risk of irreversible brain damage is between the 4 to 6 minutes. So the perimortem cesarean section, what it will do is it will improve your venous return and the cardiac output, and it will make your chest compression efficient. Because there's no more the baby, it will reduce your oxygen consumption. And it's actually primarily performed to improve maternal resus rather than the survival of the baby. As we said, we are in a difficult situation. We have to choose, we know we can't choose between the mother and the baby. The mother is the priority. So we are doing nothing to save the baby at that stage. That stage, we are saving the mother. Where can it be done? It can be performed anywhere. So basically in your emergency department, the lady is literally dead. So there's no anesthesia required. There's no cardiac output, so there will be no blood loss. If the resus is successful, then you can transfer for anesthesia and analgesia and completion of the cesarean section. So that is a picture of uterine displacement. And I've never done it, but it is easy. I have been told there's a one-hand technique with the picture on the left, and then the two-hand technique with the picture on the right. Because the woman has got no tone, it's very easy. You can easily sort of move it. And, you know, we do uterine displacements, I'm sure, at time of cesarean sections and all. Also, we are sort of, you know, correcting the tilt and things. So I don't think it is very difficult, but I think there's the only picture that is circulating in the. Okay, so we've talked about, you know, how are we going to prevent, how are we going to, you know, what are the maternal adaptations? I just thought a few slides, you know, otherwise my presentation may not look like complete, is what are, you know, what are the things that we do. So alert your obstetric and anesthetic consultants, especially out of hours, you know, in hours they will be there and we can get access to them. So if there is, you know, we're very difficult to preempt, but if we can, then yes. So we've got a you know, a crash call, and that goes to all the people who are responsible. And then ask for your resuscitation trolley, perimortem cesarean section pack. Now, you know, we've said that it's on the cardiac trolley and labor suite and resuscitation equipment, but, you know, we've got a perimortem cesarean pack even in our emergency and accident and emergency department for that purpose, that you don't have to go looking for, because, you know, time is the essence at that stage. So you don't have to look for it. It is there on the emergency trolley. So lie woman supine with left lateral tilt. So you can do that with 30-degree wedge, pillow, or even your own knees, open airway, assist breathing. And this is, you know, this is like me teaching you all, which, you know, this is the basic life support. I'm sure everybody knows. Nothing is different at this stage. Your chest compression to breath ratio is 30:2. You assess the rhythm, and if it is a Delver shock, if it is appropriate, carry on perimortem cesarean section. And, you know, if your resuscitation is unsuccessful within the 4 minutes, and during the operation, you carry on with your CPR. So you don't stop your CPR. This is for the management. So obviously, once you've resuscitated the patient, then you investigate and monitor. During resuscitation, we've talked about, you know, giving them oxygen, secure wide bore cannulas, send off your bloods, diagnose and correct the reversible 4 Ts and the 4 Hs, and give your other medication. CPR should only be interrupted if there are signs of life or if we have to give the patient shock. If the cardiac output, we've talked about this again, transfer the patient to theater for suturing, anticipate, you know, most of pregnancy conditions, PPH and DIC go hand in hand. So think about that. And then investigate according to, you know, your basic, and it may include, you know, your bloods, ABG, your acid blood gas, your ECG, chest X-ray, and transfer to ITU is pretty much the norm in these sort of cases. So there was one case report in our Embrace report, I think it was from 2014. So our Embrace is any maternal death is reported, and that is our reporting system. So this lady was a 29-week-old primip. She had type 2 diabetes and obesity. At 32 weeks, she presented with a 3-week history of worsening shortness of breath and cough. She was seen by the obstetric team in accident and emergency, and it always happens on a Friday evening. All these things will not happen in the weekdays, they'll happen on a Friday evening. So the diagnosis of infection or pulmonary embolism, and then she was sent home. Over the next 2 days, she complained of intermittent shortness of breath and oxygen saturation. On Monday, she was transferred for a Vicky scan. And at that stage, she was not accompanied by medical staff, and positioning wedges were not used. Around 20 minutes into the scan, she had a cardiac arrest. The arrest team was called. She had full resuscitation, including a perimortem cesarean section at 15 minutes. And this was performed, and a return of spontaneous circulation was there in 20 minutes. Woman was transferred to intensive care, where she remained for 11 days. She did not regain consciousness, and her CT findings suggested severe hypoxia and brain injury. And sadly, she died, but the baby did survive. So the recommendations from this report was that the arrest team should be well versed in cardiac arrest in pregnant women, and then obviously early recourse to cesarean section. So there was another Embrace report in 2012 and 14, where they carried out about 32 perimortem cesarean sections. 19 babies were born by perimortem cesarean section after 32 weeks gestation. So 9 survived of that. 6 had stillborn and 4 died in the neonatal period. And then there were 13 babies who were born by perimortem cesarean section, but that was at 32 weeks or less. And 10 babies were died of that. 4 were stillborn and 6 died in the neonatal period. So thus, 38% of the total 32 babies delivered by perimortem cesarean section sort of survived. 1/3 died in the neonatal period and 1/3 were stillborn. There was another study, which was UK obstetric surveillance system, and they decided to look at all the cardiac arrests in pregnancy. And that was a study, I think, for 3 years between 2012 and 2014. So in that, there were about 16 cardiac arrests in pregnancy, and that sort of gave the incidence of 2.78 per 100,000. So even, and that was for cardiac arrest. So even then it is, quite rare. 28 women died, so that gave the case fertility ratio of about 42%. 16 women arrested with obstetric anesthesia, and 12 of them were obese. So we know that obesity is a risk factor. Basic and advanced life support were rapidly done for all of these. Those who died were more likely to have collapsed at home. And I haven't put the numbers, but there was a good proportion who collapsed at home, and those, the survival was less. Perimortem cesarean section was performed in, I think, sorry, I can't see my slide. And 11 were done in emergency department. But the basic thing was that those who we did the perimortem cesarean section earlier, their survival rate was much better. Those who, there was delay, their survival wasn't. So conclusion was that cardiac arrest is rare in pregnant population. Nearly a quarter of these are precipitated by the obstetric anesthesia, and all of them, I think, survived in this. So that is an opportunity where we can reduce these further. Survival rate, they've said around 58%, and it was more like when they were inpatient arrest, then they were, the outcome was better. The outcome was worse when they collapsed at home. Okay, so that is this. I just found a picture and I thought, it has been a bit, so we can laugh. This is just showing, how the tilt sort of changes your aorta and vena cava's diameter, so how compressed it can be. And then if there's no return of your circulation, then by 4 minutes, get the baby out, and that's for the sake of the mom. And then the C-section team, it says scalpel, scissors, and gloves. And actually, you just need plus cord clamps. That's all you need. So I don't know how much time we have. There's a video which is about 11 minutes. And I can...
Yeah, Nutan, please go ahead.
Yeah, okay, fine. So I'll just do my thank you slide and then I will stop sharing because I did an effort at the thank you slide. So
Wonderful efforts, Nutan, and yeah, please go ahead with your video.
Yeah, so I'll just stop sharing this for a minute and then I'll share again.
Yeah.
And this should work because I have shared sound.
Welcome to this prompt interactive scenario. In this video, you'll be observing a clinical team managing an obstetric emergency. The key objectives of this session are to provide a refresher of the clinical management of a woman with severe preeclampsia, to discuss the local systems in place in your unit for managing.
Sorry, I have gone to the wrong video. Sorry, I just need to unshare again. So sorry, I think it's... Sorry, guys, I will be with you in 1 second. Something can never be too prepared. Sorry, I'm just going to share that again in a minute.
Very nice talk, Dr. Nutan.
Thank you. I'm just hoping to get
Can
this.
I ask you one?
Just 1 second. Let me get this video on, and then I will.
Hello, everybody.
Hello, madam. Good
Hello,
evening.
Hello, hello.
Hi, Sheila.
Hi, Vijaya.
Hello, Vijay.
Hi, Varsha.
Varsha. Hi.
Namaste, Sheshadri.
Priya, Dr. Jayam.
Okay, sorry, I'm just
leader, Dr. Lakshmi.
Again.
Hello, ma'am. Hi, hello. Hi, Jyoti.
टेबल में भी देख लेना एक बार आइए आपके चैम्बर में.
Jyoti is looking different today.
Okay, I think I'm ready. And this is for, it's at the time of COVID, but you know.
और मैं देखो वो ब्लूटूथ का डिब्बा था.
When it does occur, the
मेरे
risks
चैम्बर से ना तन्नू चीजें गायब हो रही हैं.
are consideration. Any patient in a healthcare setting may have COVID-19. UK and international resuscitation bodies deem chest compressions to be aerosol generating, so appropriate PPE is needed. Because PPE takes time to don, key team members should don full AGP PPE if caring for a woman at risk of deteriorating into cardiac arrest. The Resuscitation Council have produced a guide to help teams safely manage cardiac arrest during this pandemic. Firstly, recognizing cardiac arrest. If a woman collapses, check for signs of life by placing a hand on the chest or, if trained to do so, checking for a pulse. If there are no signs of life, call for help. Unless you're in full PPE, do not start chest compressions, but prepare the woman for the team's arrival. The woman's nose and mouth should be covered, ideally either with an oxygen mask or a surgical face mask. Manual uterine displacement can also be performed whilst awaiting the team. In the team responding to the emergency buzzer, the first responder ascertains the nature of the emergency and relays it to the team, and then acts as gatekeeper. The 2222 cardiac arrest call should ideally notify both the maternal and neonatal resuscitation teams about the potential for COVID-19. The resuscitation equipment should also have PPE available for the first responders. Many units will keep the main resuscitation equipment outside the room and pass items in as they're needed. Since defibrillation is not aerosol generating, attaching a defibrillator is a priority. If the rhythm is shockable, defibrillation should not be delayed and can be done whilst waiting for the team to don PPE. If an oxygen mask is attached, turn it off at the wall before shocking. This way, the woman's nose and mouth are still covered. Once full aerosol generating procedure PPE has arrived, the team don. As this is a maternal emergency, the anaesthetist is prioritized to don first, assisted by another team member for efficiency. Additional PPE for the whole team should also be obtained. Once the anaesthetist is confirmed ready, they can take their airway equipment and enter the room. However, they do not start resuscitation until those without full AGP PPE have retreated to a safe distance. As the rest of the team arrives, they take on their respective roles. Airway intervention should be performed by someone experienced. Two-person mask ventilation and intubation can be done by those with expertise. During resuscitation, the uterus should be manually displaced. Reversible causes of cardiac arrest need to be considered. In pregnancy, this includes delivery of the baby, ideally within 5 minutes of collapse. If the neonatal resuscitation team in full AGP PPE prepare their equipment outside of the room, they can then receive and resuscitate the baby in an area that minimizes the team's potential exposure to COVID-19 from the mother. The maternal resuscitation continues, swapping team members as they tire, using grab bags to obtain equipment such as for cannulation, use an algorithm to guide the treatment. If there is return of spontaneous circulation, post-resuscitation care should be planned. After the resuscitation, all equipment used should be disposed of or cleaned according to national and local guidelines. Airway equipment especially should not be left lying around. Yanker suckers can be placed in a glove and disposed of. PPE must be removed carefully in accordance with national and local guidelines in order to minimize the risk of contamination. Gloves first, followed by hand hygiene, and then gown and eye protection. FFP3 respirator is removed outside the room before washing hands with soap and water. Debrief is important after a rare event like this, even when there is a positive outcome as shown here. It helps the well-being of the team, allows personal and organizational learning, as well as to support the partner, the family, and at a later date, the woman.
Okay, so I'll just stop sharing. So that was a video from our prompt training. We can use as long as we acknowledge them. So there are loads of other prompt videos that which you can. Okay, so that was the end of my presentation. I hope I've finished on time.
Thank you very much, Dr. Norton, for your excellent presentation and more for your video. That I think this video should be a simulator video, because I don't think that any of us will dare to go for a video coverage or anything when we are doing a meeting with the obstetric collapse, which is a very rare thing. And of course, your simulation is wonderful. I think apart from the COVID part of it, everything has to be done by every team which is doing obstetric drill. The secondly, your UCAS and EMBRACE data are excellent. This is what we are trying to get it in India. I think now a stillbirth team has been formed, and we are soon, in a couple of years, we will be getting the stillbirth data, provided all obstetricians throughout India send the data to their team. That is where we have got such a huge volume of lakhs and lakhs of deliveries, but we have shortage of our writing material. I think in the next decades to come, the juniors like Supriya and others will take it up and see that in their chairpersonships, the data are the main thing that come up rather than the clinical meetings talking about past, present, and am I right? Thank you very much, Newton. Do you have any questions for Dr. Newton?
I think Dr. Sheila, ma'am, good evening. You were asking Dr. Newton a question.
No, I was just thinking that what about the consent? Like, do you take the consent for the perimortem cesarean?
No, because I mean your patient is dead, so it will come under best interest.
Yes.
Because in India, the scenarios are so different, like.
No, I think, Sheila, with India also, the scenario is a protocol if it is maintained by the hospital, and the hospital gives the details to the patient in advance, that such things will be done without consent. One of that is perimortem cesarean section. This is what is the recent obstetric protocol, especially even in Lakshya, they are thinking about this to be included. Lakshya is a government program which is done for the corporate hospital. They are trying to include what are the things which will be done without information. A couple of things are going to come, in which perimortem cesarean is also going to be one.
Okay, good.
Can I share one patient of mine? Can I just share one very remarkable patient?
The organizers have got time, Jyoti?
If very briefly, Dr. Mitra.
Yeah, I want to say that it was a very high risk IVF, severe hypertensive patient who walked in at 11 o'clock in the night with very, very high blood pressure, and she went into pulmonary edema. I could see that she's going to die because she was in my examining room and the ultrasound machine was there. I could see the fetal heart. So I immediately called the husband and I did a post-mortem or perimortem cesarean. We couldn't save the mother at all, obviously, but the babies could be saved. And this is a very, very rare opportunity anybody can get to to save lives. So I just thought to share.
Dr. Mitra.
Yeah. So perimortem cesarean. Yeah, thank you, Dr. Mitra, for sharing that. And very rightly, as Dr. Jam ma'am is also saying, cesarean we can do without consent. So that is what, and it can be done anywhere. There's no need to do anywhere, take her to OT and all that.
No,
It
no.
can be done in
You have to just need a scalpel and
So thank you so much for that wonderful, wonderful presentation, Dr. Nutan, and I'm sure we'll
Jyoti, can I give one message of advice to all the juniors? Of late, with the obstetric anesthesia and intensivist work going on, lot of diagnosis of cardiomyopathy in patients with pregnancy-induced hypertension postpartum are being made without knowing the physiological changes that the pulmonary edema can be caused by the return of fluids if it is going to be overloaded during anesthesia. So I request all the juniors to think of transient pulmonary edema rather than taking up the cardiologist's opinion as acute cardiomyopathy. This is one area which we have been handling these patients without being sent to the intensivist, and I request all the juniors to take up this message and do it appropriately. Thank you.
Thank you, chairpersons. Thank you, Dr. Jayam ma'am, Dr. Supriya, and thank you, Dr. Nutan. We would be listening to you again in the panel discussion now. And coming on to our second topic is shoulder dystocia, because बच्चे की गर्दन अटक गई तो obstetrician की भी गर्दन मतलब it is gone. So similar way, another very distressing situation of shoulder dystocia. To chair that this session, we have none other than Dr. Sheila Mane ma'am, whom we all know, we all understand what work she has done for Indian women regarding our PPH, managing PPH and preventing PPH across India. Ma'am is a DNB faculty at KCG Bangalore, and she is also ICOG Governing Council member, also President ISOPAP Society of Bangalore. And the second chairperson, a person who showers everybody with lots of love and wisdom, is Dr. Varsha Baste. And Dr. Baste is practicing in Nasik for last 30 years. She is director, Pushpa Fertility Center. She is CEO, founder of Cellgen and Anti-Aging Center, the first adult stem cell center therapy in the West India. And she is first have to have the PGD baby in North Maharashtra, past president of BGY Society Nashik, and chairperson of FOXI IAEC. So done a wonderful, wonderful work in her tenure for this particular post. So welcome, Dr. Varsha Baste, and
Thank you.
To introduce our speaker, Dr. Deepa Nair.
Yeah, may I have the slide? First of all, let me thank from my bottom of the heart. I'm repeating your word, Dr. Jyoti Malik, because I can see after long, so many stalwarts like JK Madam hai, Sheila Mane ji hai, also Lakshmi Sikandel, Jyoti Malik hai, and so many known people and friends, and all the abroad faculty also I know many of them. So it is a delightful drill, part one, and I'm invited. So I feel really blessed to have me here. And the first part was really sixer tha, bahut acha tha, collapse. Very well presented, and the remarks by Dr. JK Madam was really appreciable. So now the second topic is definitely the same important, dystocia by Dr. Deepa Nair. She is a consultant OBGYN from Brugg Healthcare NHS UK Trust, and completed masters from Kerala, completed DNB from UK, did diploma in medical education from Cardiff University, and many other credentials to her. Currently working as consultant in OBGYN, educational lead at Buckingham Hampshire Healthcare NHS Trust and keen interest is in medical education. So, ladies and gentlemen, may I present you Dr. Nipa Nair, who is going to present us managing the shoulder dystocia, which is really important for this today's topic. Over to you, Dr. Deepa.
Good evening, everybody, and thank you for that warm introduction. I'm just going to try and share my screen. So I'm Deepa Nair. I currently work as a consultant in Obs and Gynae at Buckinghamshire Healthcare NHS Trust in the UK. I have had the proud privilege of being trained duly in 2 countries, both in India and UK, and truly value my experience in India. It is a pleasure to be presenting before all of you all today, many of whom I've seen through my postgraduate training years, and I thank the organizers and Ms. Mishra for giving me this opportunity. My topic for today is shoulder dystocia. Why is it important? The incidence of shoulder dystocia is not high, 0.58 to 0.7%, but it has important implications on the baby, the mum, and on the obstetric team. The fetal implications include brachial plexus injury. While about 4 to 16% of shoulder dystocia births will result in brachial plexus injury, only 10% of these last beyond a year. The incidence of permanent injury in the UK is about 1 in 2,300 live births. It can cause neonatal fractures, most commonly the humerus and the clavicle, and of course the most dreaded hypoxia and stillbirth. Maternal implications include perineal injury, hemorrhage, and traumatic experience to the mum. Impact on the obstetric team. When the topic was introduced by Jyoti Malik, as she said, this has significant medico-legal implications in addition to the mere trauma that it causes to the obstetric team. And what is the role of training then? The fact is, it is not very common. Again, like maternal collapse, we're not going to get what we would like, hands-on training in a situation like shoulder dystocia. Majority of cases occur in women without any risk factors. It is unpredictable. We all have to be prepared at all times. Clinicians should, however, be aware of existing risk factors and make appropriate recommendations for the best place of birth. So if we do have risk factors, we need to anticipate the situation and try and bring the woman in a position where she can get help to the best we can. As I said, clinicians should be alert to the possibility of shoulder dystocia with any birth, and multi-professional learning has shown to improve outcomes. Shoulder dystocia is defined as a vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has delivered and gentle axial traction has failed. It occurs most commonly when the anterior shoulder impacts against the symphysis pubis. There can also be situations when there is impaction of the posterior shoulder against the sacral promontory, and even rarer, it can be a combination of both. Now, like Ms. Mishra said earlier, I have used a lot of slides from PROMPT, and PROMPT is the practical obstetric multi-professional training done on a regular basis in the UK, and we're allowed to use the slides provided they are acknowledged. A very frequently used analogy is a truck and a low bridge situation. The front part, the cab portion of the truck, gets through under the low bridge, but the back, which is more bulky, cannot. The risk factors Previous shoulder dystocia can result in a recurrence rate of as high as 25%. Fetal macrosomia, the big baby, again a risk factor. Maternal diabetes mellitus, obesity, what we see quite a lot now, a prolonged first stage of labor, prolonged second stage, augmentation of labor, and operative vaginal birth. All current international guidelines recommend the use of 4 basic resolution maneuvers, the microbirths, and we also tend to propagate the all-force microbirths. I will talk a little bit about that later. Suprapubic pressure, and then delivery of the posterior arm or internal rotation of the shoulders. This is an algorithm, and I will go through each step in detail. I'm sure most of you will be quite well versed with this, but I think it's always helpful just to reiterate these algorithms so that we know what we're doing when we're faced with the rather rarer situations. The initial step is recognition. Shoulder dystocia should be anticipated if there is slow and difficult delivery of the fetal face and chin. When the fetal head is delivered, it remains quite tightly applied to the vulva. The classic turtleneck sign of chin retraction should be looked for. The anterior shoulder then fails to deliver with routine traction. The first thing to do is call for help. Clearly state the problem. The most experienced staff should attend. That would include, in our situation, the experienced midwives, the experienced obstetrician, which would be the consultant, healthcare assistants whose help is invaluable in such a situation, the neonatologist, and the anesthetist and theatre team should be on standby should we need to go to theatre for any reason at all. The first, most tested, and most effective maneuver is the microbirths maneuver. This picture demonstrates how the woman's legs should be hyperflexed and abducted with her knees drawn to her chest. The first thing would be for the woman to lay completely flat, advised to stop pushing and come to the very edge of the bed. The mother's bottom should be lifted off the bed. And essentially what this maneuver does is it increases the relative anteroposterior diameter of the pelvic inlet and makes the pelvis more upright. With each maneuver, apply routine axial traction to the fetal head to assess if the maneuver has been successful or not. This is another picture just demonstrating the position. The all-4 microbirths, which I mentioned earlier, is more relevant if there is only a single attending obstetrician or midwife. It is easier sometimes to put the woman on all fours and emulate the same maneuver. A simple change of position may actually help release the shoulders. And again, routine axial traction can be applied to assess if the maneuver has been successful. Now, the sacral hollow here is accessed anteriorly, and if any internal maneuvers are required in this position, it is important for us to remember. And I think as obstetricians, we often struggle with this. Well, our midwives tell us a lot about all fours. It's not something that comes to us very easily. So personally, I'd still be comfortable with the patient laid on her back. Now, what is routine axial traction? It is the same degree of traction as applied during a normal birth in an axial direction. It should be applied with the axis of the fetal spine. It should be done only to see whether each maneuver has been successful or not. The next is suprapubic pressure. This aims to reduce the diameter of the fetal shoulders and rotate the anterior shoulder into the wider oblique angle of the pelvis. Suprapubic pressure should always be applied from the side of the fetal back in a downward and lateral direction. So it's important to tell your assistant which side the fetal back is, and this is recognized by the side that the occiput of the baby faces. Again, apply routine axial traction to the fetal head to assess if the maneuver has been successful. The next we have the internal maneuvers, and this is where the algorithm divides into two sides. Evidence shows that both these can be tried and do not necessarily need to be done in succession. Obstetricians more comfortable with delivery of the posterior shoulder can do so at this stage. And on the other hand, if it seems like the internal maneuvers are going to disimpact the shoulders, then that can be done as well. What we need to remember is that there is no room under the pubic arch, and the most spacious part of the pelvis is the sacral hollow. A scrunched up hand, often referred to as the Pringles maneuver, can be used to enter the vagina posteriorly. Delivery of the posterior arm will reduce the diameter of the shoulder by an arm's width. The fetal arms often lay flexed across the chest. The obstetrician enters posteriorly, feels for the fetal wrist, grasps the wrist, and gently releases the arm in a straight line. The internal rotation maneuvers as well help to move the impacted shoulders from the narrower anteroposterior diameter to an oblique diameter. Apply pressure to the back or the front of the fetal shoulder, depending on axis, to rotate the fetus into an oblique diameter of the pelvis. Addition of suprapubic pressure while this is done from an assistant may help further disimpaction. Now, what is important to remember is what not to do. There is good evidence to show that as long as the time between delivery of the head and the whole birth of the baby is less than 5 minutes, the risk of injury to the baby is low. These 5 minutes to the obstetrician perhaps most times appear longer than 5 hours. But we need to be thoughtful, work out what the actual mechanism is, and do not do anything that will result in more harm. Do not pull hard. Do not pull downwards. Don't pull quickly or with a jerk. And there is insufficient evidence currently to recommend traction at the axilla. Something that I had seen earlier during my postgraduate days is fundal pressure. Fundal pressure, again, should not be used in shoulder dystocia because it is only likely to increase impaction. Hopefully, we would have achieved delivery of the baby successfully within 5 minutes. And then we have the important aspects of documentation and debriefing. For documentation, it is important to record the head and body delivery times, who was present at birth and who was called, which maneuvers were performed, and what the order of the maneuvers done were, the degree and direction of traction applied, the anterior shoulder at the time of dystocia. And this is quite key because that would imply as to whether the maneuvers resulted in any injury or whether it was the initial impaction itself that caused the injury, and that doesn't need to come on the obstetrician or the delivering personnel. Condition of the baby at birth should be documented, including their abgas, the cord PHS, and what the signs of neonatal injury are. We do have standardized documentation pro forma in the UK. This is a standard pro forma by the prompt, and it would be good for every establishment to actually develop their own pro forma based on this. Postnatal care. The baby needs to be reviewed postnatally. It is really important to debrief the parents, and we also debrief the team involved because it tends to be quite a stressful situation, and it is important for learning as an organization. We have information leaflets for parents. There is one for the RCOG website itself, A Difficult Birth, What is Shoulder Dystocia? And we also need to refer for mode of birth discussion for the next pregnancy, as these women usually are quite traumatized by the whole experience. I'd like to conclude with quite a sad story, but I think there is a lot of learning from this, and it also goes to show a lot about consenting and antenatal counseling of patients. This is Nadine Montgomery and her son on the picture that you see. This was a landmark case in the UK, Montgomery versus Lanarkshire Health Board. Nadine Montgomery's son was born with cerebral palsy as a result of shoulder dystocia during birth. Mrs. Montgomery was a pharmacist herself. She was around 5 feet tall, diagnosed to be diabetic in pregnancy, and she knew that this often results in larger babies. She had raised concerns that her baby may be too big to be delivered vaginally, but had not asked about what the exact risks were. Evidence showed a 9 to 10% risk of dystocia where a diabetic woman gives birth via vaginal delivery. But Mrs. Montgomery wasn't warned of the risk of shoulder dystocia or offered a cesarean section as an alternative. The treating obstetrician, a consultant in Scotland, she felt that if Mrs. Montgomery was told of the risk, she would have opted for a cesarean. She didn't believe that this was in the best interests of the patient. It was accepted that shoulder dystocia can cause serious complications for the mother and the baby, but it was also known that the risk of cerebral palsy was low at around 0.1%. Mrs. Montgomery claimed for negligence, arguing that she should have been told of all possible risks. She was awarded £5 million in damages after an appeal went to the Supreme Court. Why this was a landmark case is that she fought for over 10 years, was rejected in several courts, and then finally went to the Supreme Court and got her case sorted. The questions this raised about consent. Before this Montgomery ruling, a doctor's duty to warn patients of risk was based on whether they had acted in line with a responsible body of medical opinion. So when Mrs. Montgomery lost this case at the High Court, it was because a body of consultants said that that is exactly what they would have done as well. And this was accepted and known as the Bolam test. The court, however, when it went up to the level of the Supreme Court, accepted that if Mrs. Montgomery had been told about the risk of dystocia, she would have chosen to have a cesarean section. And that essentially is what made her appeal successful, that the assessment of whether consent was adequate in a clinical negligence claim could not be assessed by the Bolam test. Instead, doctors must provide information about all material risks. They must disclose any risk to which a reasonable person in the patient's position would attach significance. The judgment, therefore, means that doctors must share all material risks, as well as any to which it would be reasonable for them to think that the individual might alter her choice. In this case, what Nadine Montgomery said is that she would have opted for a cesarean section and her son then would have been well now. This was a huge case in the news, and I thought it's quite worth sharing and something to reflect upon in our own practice and what we think is medical paternalism and patient choice. I'd like to conclude my presentation with that. This is an algorithm, and in a gist explains all that we need to do for management of shoulder dystocia. Thank you for your patient listening, and I'm happy to take any questions that you may have.
Thank you, Dr. Deepa Nair. Such a elaborate, such a nice talk by you, and precisely every step you told, how to manage it, how to document. I would like Dr. Sheila Mani to give the concluding remarks, and before that, I also want to congratulate Dr. Mitra, Dr. Surekha, Dr. Supriya, Dr. Tadas, and all present here. We are all together, and I'm really happy to see all the known faces. Thank you. Over to you, Dr. Sheila Mane.
Yeah.
Give the concluding remarks.
Yeah, Dr. Deepa. Excellent deliberation, I think, and the way you explained, and with all the presentation, it was so easy to understand. Now, I just would like to know that you have mentioned that in document you should mention about the anterior shoulder. I would like you to elaborate little bit on that.
So shoulder dystocia could happen because the anterior shoulder impacts against the symphysis pubis, and that is the most common occurrence. It could also happen when the posterior shoulder impacts against the sacral promontory, or rarely both. Now, what happens during rotational maneuvers? There can be two things. The injury to the brachial plexus can be due to the very event that resulted in the baby being stuck, or it can result from arm maneuvers. So documentation should be quite distinct and clear to tell us which shoulder we moved. So if we remove the posterior arm, and it is the anterior shoulder of the baby at delivery which had the problem, I don't think the onus in a court of law would go on to the obstetrician. So legally, it does have implications to say which is the arm that you actually delivered and how was the baby facing at presentation.
But looking at the lady who said that for 10 years she fought for against the doctor, ये तो दुनिया ही छोड़ दो, ऐसा हो गया कि obstetric ही छोड़ दो.
नहीं वर्षा, उसका take home message is too good that we should not take decision on behalf of the patient, and that is why she has stressed that we should give all options to the patient and let patient decide and document that. You have explained and patient has opted for
Documentation
this
is very, very important. That we take it like
recently, one of my case where I did not expect anything. She delivered, I mean, vaginally, and there was a shoulder dystocia, but I could deliver her easily. Okay, I mean, just only with suprapubic pressure and hyperflexion. But baby had the anterior shoulder. Okay, as you mentioned, there was a weakness and there was a Erb's palsy. So I was surprised that I haven't applied much traction, and I delivered her in 2 minutes after it happened. Still, why did it happen? So that is why I wanted you to elaborate on that anterior shoulder, because I knew that it was the anterior shoulder where there was a problem and the baby had brachial plexus palsy. Now, luckily, with all the treatments and everything, the baby is doing fine, 6 months old. So that is why. So if there is an impaction earlier, you know, even that's what you mean, that anterior shoulder gets badly impacted, can also give rise to these problems.
Yes.
Yeah,
absolutely, Dr. Malik. And what I wanted to also say is that we all work in very, very stressful environments and do our best to save the patient. The only thing that can protect us is documentation, because everyone finally wants to put the blame on someone. And suppose we have documented, I think as a profession, we need to be able to look at it factually and say that this is what happened. Well, could it have been prevented? If the answer is no, it is a no. Everything doesn't necessarily need to be put on the obstetrician who actually saved the situation rather than created the problem.
So the take-home message is documentation treated as practical.
That patient asked me, "Doctor, did you only deliver my baby or your assistant? Okay, and how much time you took?" All those questions were in her mind. And when I told her everything, what all happened during labor, I explained it to her. Then she was relieved. So I told her that I myself am surprised because I was there and I delivered you so quickly and not my assistant. And I have not even applied too much of traction also. The baby is doing fine. I could do shake hand with the baby just 2 weeks back. I was happy. But, you know, sometimes I have also faced a neuropraxia where those days no ultrasound and the baby was 5 kgs, which I did not realize. Second gravida, I have only delivered. It was a typical turtleneck. I don't remember what maneuvers I have done. I delivered that baby because, you know, I wanted to see that the baby does not develop asphyxia. But it was a complete tear. And the baby had to undergo nerve grafting. Okay, she's 23-year-old today. She's a graduate. She's doing fine. So, you know, I mean, the only thing is the empathy, and we have to explain everything to the patient. So these are 1 or 2 experiences which I thought I will share. So nerve grafting was done. Yeah.
Thank you, Dr. Sheila ma'am, Dr. Varsha Baste for chairing that wonderful, wonderful, scintillating talk by Dr. Deepa. It's very, very explicit. And I'm sure we should all be doing regularly these drills, and we should have that chart displayed in our labor room near our delivery tables, how to handle a shoulder dystocia, because we can be caught unaware anytime. Not all shoulder dystocias are when we expect them. We can get caught at the wrong foot sometimes. So we should all be ready with the drill. And coming on to the very, very interesting panel discussion on shoulder dystocia and maternal collapse, I would now like to invite our national coordinator, Dr. Sushma Verma, who is the director and consultant at Savodaya Hospital, Raipur, to please take over from here for this interesting, the second important and interesting half of the scene of the webinar. Thank you.
Thank you very much, ma'am. First of all, I want to thank our speakers for very nice lectures on the based on the practical tips. And after elaborate and wonderful lecture on maternal collapse and shoulder dystocia, now I would like to invite our moderators and panelists for case-based panel discussion. For this, I would first invite Dr. Mitra Saxena ma'am and Dr. Surekha Tade ma'am as moderators for the panel. Dr. Mitra Saxena ma'am is a director and senior consultant Shri Ashwini Saxena Hospital Rewari, and she is the chairperson of Practical Obstetrics Committee FOXY 2021-24. She is past president of and now the patron of Rewari Obs and Gynae Society and contributed many chapters in various books. Surekha Tade ma'am is a professor and unit head of JNMC Savangi Wardha, and she is the director. She is the chairperson elect of FOXY Clinical Research Committee. She is the she is a member of IMS Education Committee and chairperson of Global Women's Health Task Force, and she is the core faculty of Dhira project of FOXY. Now I would like to invite our esteemed panelist, Dr. Mala Srivastava ma'am. She is the head of Gynae Oncology Unit and senior consultant at Gangaram Hospital, New Delhi. She was vice president. She is vice president elect ISOPAP 2023-24, and she is the receiver of many awards. And then I would like to invite Dr. Vijay Lakshmi Sheshadri madam. She is a senior consultant Obs and Gynae, Sundaram Medical Foundation, Chennai. She is past president of OGSSI and past Chennai chapter secretary of IMS, and she wrote many chapters in many books and receiver of many awards. And now I would like to invite Dr. Abha Rani Singh ma'am. She is the professor and HOD of Obs and Gynae SKMC Muzaffarpur. She is ICOG Governing Council member, past president of Patna Obs and Gynae Society, and contributed many chapters in various journals and receiver of many awards. And now I invite Dr. Mosmi Tedas madam. She is associate professor of GMCH Nagpur and fellow of ICOG, and she had many publications in various national and international journals. Welcome you all, ma'am.
So, Dr. Sushma, can I start?
Yes, ma'am. Please start, ma'am.
Okay, thank you so much. A very warm good evening. Welcome to everybody. Thank you to Dr. Lakshmi and Dr. Jyoti and Dr. Jyotsna from UK for coordinating such a wonderful session. Our jobs are very easy, basically, after the wonderful talks in tandem by Dr. Nutan Mishra on maternal collapse and Dr. Deepa Nair on shoulder dystocia. And already Dr. Sushma has elaborated on our panelists who are coming from all the four corners of the country, from south, north, east and west, and then also experts Dr. Nutan and Dr. Deepa. I will also be requesting Dr. Jayam and Dr. Sheila Mane to be there for this session as well. And of course, while I'll be taking you through the first case, we are going to do it in reverse. We started with maternal collapse. We take the case of shoulder dystocia first, and I will ask Dr. Surekha to also be a part of the panelists. So, okay, friends, Dr. Deepa has taken us beautifully through shoulder dystocia, And her first slide said that it's a harassing condition for the mother, for the baby, and for the obstetrician. So I'm not going to, waste much time, but I have shared my case, just like Dr. Sheila Mane, who has been courageous enough. We are very, very proud of our successes, but it is our failures or our shortcomings which really actually sets the stage for us to be better than before. So I am sharing my own real case. It has been shared with the panelists already, but to tell the audience, this was a third gravida. First pregnancy ended as a sad IUD. Second time when she came to me, it was a big baby, 4.25 kg. And actually she had been kept for vaginal delivery, but because of meconium, big baby, I did a section and the baby girl was fine. Then 3 years later, in 2009, because this time the baby didn't appear to be that big and she had gone into spontaneous labor. And then let me tell you, let me confess, we don't tell the patient, but we know ourselves that here is another daughter. So I thought this is a smaller daughter. And in my own mind, the calculation was, if she goes in labor, I'll do a VBAC. I myself have done a VBAC for my own self. So friends, second time she went into spontaneous labor. And I like to ease out in the second stage, I put the vacuum. And then actually the notes say something, but the reality I'm telling you. So the notes were written, everything fine, baby fine, this, that, but the reality was otherwise. The reality was that once I delivered the head of the baby with vacuum, I don't know, I panicked or the head was really retracting, but I suddenly remembered, oh God, what have I done? Why have I put her for a vaginal delivery? She's previous cesarean, and now I'm stuck with shoulder dystocia. Like Dr. Deepa Nair said, that what I shouldn't have done, this is exactly what I did. I panicked. I was, my voice was at the highest pitch. I was asking my attendant to, my staff did McRoberts maneuver. At that time, I'm not aware whether I did the fundal pressure because I'm sure I didn't do it, but we were constantly encouraging, not doing gentle axial traction because it was like as if I'm not able to take out the baby alive, I'm going to pass out. So I just thought, mere ko to nikalna hi hai. So it was a very hurried, strong pulling, and I knew I'm going to injure the brachial plexus. Anyhow, fundal pressure again shouldn't have been done, but I did it. I was cursing myself, praying frantically, but I managed to deliver the baby. But that guilt was there that I have messed up. And I think 11 years ago, all we had done was answer this question in theory. This was my first experience of managing. And fact of the matter was that my efficiency was less because I was cursing my decision that why have I put off a vaginal delivery. So the thing is this, that I immediately checked the baby and I found there was paresis, although the pediatrician missed it. Of course, the family didn't know. But what I did was within a week, I thought it is, ethical for me to tell the patient because they went back very happy, thankful, grateful, madam, you haven't done a cesarean, baby is fine, feeding, everything was fine. I was guilty because I knew there is weakness of the upper limb. So in a week's time, I took my time, composed my own self, and then I broke the news and I said that I'm sorry, there's something wrong. There is a little bit of pressure on the nerves. We have to go for orthopedician and physiotherapy. And well, I held her hand throughout. Now the girl is 13 years old. She has very, very little weakness and parents are very happy. But this doesn't really happen. So what happens is, as has been elaborated by the case in UK, and very soon in India also we would be having these patients. So I'll ask Dr. Mala that even though I have written it, but let her enumerate all the mistakes I did so that the audience doesn't do it. Let us be very open about it. Dr. Mala Srivastava.
Thanks, Dr. Mitra. I must thank Dr. Lakshmi and Dr. Jyoti for giving this opportunity to us to be a part of this nice panel discussion. Dr. Mitra, you had this patient, she had previous cesarean and the earlier baby was 4.5 kilo. Though you thought this baby was lesser in weight and you could have given a VBAC to her. But the point is this, we have to discuss all the pros and cons of VBAC with the patient, give them the facts, the risk, and take the informed consent for VBAC and then go ahead. Of
So
course,
in this patient,
had
Dr.
delivered
Mala,
earlier.
What I had said was that if she goes into spontaneous labor, which she did, and the labor progressed uneventfully. So I am asking, was my decision wrong or it was okay?
See,
where did I mess up?
Basically, when we have a case of previous cesarean, we must discuss with the patient the pros and cons of VBAC. We must have a communication and discussion with the patient. Of course, we can say that if the patient goes into spontaneous labor, there's more chances of normal delivery for this patient. But assessment of the weight.
Dr. Mala, I want your honest opinion. The first line, actually, I had tackled it very well. She was definitely went into labor. Now I want to ask you, I did mess up. Baby did have Erb's palsy. So what was my decision of delivering vaginally wrong, or I messed up somewhere else?
See, basically, the patient had previous cesarean, and the weight was 3.4 as assessed by you, and she had gone into spontaneous labor. So she was a candidate for VBAC as well. So once the patient had the turtle sign,
that
the
I
preparedness was not there.
I didn't do the shoulder dystocia drill.
Yes, the preparedness was not there. Yeah. As soon as the patient showed turtle sign, then the preparedness should have been there. Immediately, you should have done the macroverts maneuver, not give fundal pressure. You should have given suprapubic pressure and then delivered the baby without getting panicked. You should not have panicked. You should not have given fundal pressure. These are the points where we should not have done it. Of course, you can land up with shoulder dystocia anytime in any kind of delivery. But the maneuver has to be done. Preparedness has to be there. You have to do macrobots immediately. Give suprapubic pressure. Try to deliver the baby.
Dr. Mala, I think you've already given the answer that in this case of mine, where I faltered was that I didn't do the drill properly. That's it. We will come to the
Mitra, can I add here? Why did you do the vacuum delivery? See, sometimes...
No. See, I'll tell you what. I, like in previous cesarean, either I apply outlet or I do vacuum at the second stage to just shorten the second stage.
No, but why I'm saying is because maybe the normal progress was not happening.
Yes.
Or you were a little frantic. Abba, please, can you mute, Abba? Abba, can you mute?
Anyhow,
I was just wondering whether since you applied vacuum, maybe normally the head was not progressing. There was a little bit of delay. And if you are overseeing that kind of a delay, maybe we suspect sometimes something is getting stuck. So if you apply vacuum a little ahead, maybe you won't be able to really see whether that delay is happening.
I agree with you. Instrumentation is one of the precipitating factors for shoulder dystocia. But actually, I wanted to draw the attention of the audience that I messed up the dystocia drill. I panicked. Otherwise, once the head was out, I could have waited. I could have waited for restitution. I could have waited for macrobids and suprapubic pressure, everything. I just didn't do that properly. And I was doing fundal pressure. I was augmenting the obstruction and I was panicking. So that's what I wanted to tell the audience, that we are not supposed to panic. We are the people in charge. And if you would have seen my file, basically these people didn't put me through litigation, although the child did have the palsy. So my documentation was absolutely zero.
And also, Mitra, you did not communicate to them immediately.
Yes.
No, I didn't. That I didn't do. That I didn't
should do
I was too disturbed. Actually, I was too disturbed. They were too happy. But I was fortunate. But maybe now we have to learn these things. Okay, thank you so much. So Dr. Vijay, just quickly, we all know Dr. Deepa has told us very nicely, but just recount the risk factors and the maternal and the fetal complications, and we'll be quick about
it's
one, two, three.
as Deepa has said in detail, as you said, the risk factors, of course, are obesity when the mother is obese, but here I don't know the exact weight in your particular case. And the status of diabetes also, I don't know, you haven't mentioned. But only my guess was the first one was an IUD. We don't know the reason. Sudden, if there was some death, and the second one was a big baby. We don't know whether there was an undetected diabetes. I'm sure you would have screened her through.
It wasn't.
But, yeah, it wasn't. But definitely that could be a factor. And post-dated, we say because, again, the baby grows a little more. But that doesn't matter if you are really guessing the weight and this well. Now, the prolonged second stage and prolonged first stage, both are sort of indicators, because then we know that the movement of the fetus down is getting delayed or retarded. So maybe something is happening there. Either the rotation is not happening, or maybe the descent is not very satisfactory. Quite an early induction or a mismanaged induction or an oxytocin very early can also cause this, because there will be a precipitation of the pains, but still the rotation, internal rotation and all those things have not happened. Satisfactory descent has not happened. So we have to give that kind of an observation, a silent observation, and that kind of a time for the descent to happen. As far as the complications are concerned, we know any kind of trauma can happen to the mother, starting from the perineum to the cervix. And we do check for all these things. And even we do have labial tears, we do have paraurethral tears, which is very much possible when we are negotiating with a shoulder dystocia. And as far as the baby is concerned, I think we have dealt enough that there could be, starting from the Erb's palsy to the cerebral palsy, anything can happen. Of course, here any degree of palsies can happen, and we need to really discuss, and fractures of humerus and clavicles are not uncommon as well. And even in our practice, I myself have come across, and as Sheila mentioned, sometimes you haven't really done a lot of effort or negotiated, but still baby comes out with a little bit of palsy. They say it could be positional. It happened for one of my patients twice. Both pregnancies, she had the same kind, but then it got restored very early. But definitely the key is anticipate. And if it has happened, be open. Anyway, patient also knows that we have taken the effort and she is getting into some kind of a difficult labor. Better to counsel, record, and mention everything, and also discuss with the relatives.
I would like to say that the lacuna in my own case, once I had disclosed it to the family, I should not have left my notes incomplete. Yeah. I mean, the message I wanted to give to the audience was that even if you messed it up and you're not immediately disclosed, because see, if the baby is not asphyxiated, you can buy time. Because obviously, if the baby comes out asphyxiated, we are almost, on the losing ground. But our notes, of course, have to be complete. Like Dr. Deepa has mentioned, and we'll be, really have to mention it, that there was dystocia. These are the things we've done.
Yeah. There is no escape.
We will come to that later.
Yeah.
Now, Dr. Marshami, can you please enumerate all those things which should be done, as preliminary whenever you are in this kind of position?
Yes, ma'am. Good evening, all of you. First of all, I would like to greet everyone and welcome you all for this good, nice discussion on shoulder dystocia drill. So, regarding the management of this condition, I would like to say, like Deepa Madam has already said, that all the conventional risk factors, whenever they are present, these risk factors, they have a poor predictive value. And whenever the most low risk patient can also land in with shoulder dystocia. So the first and the foremost thing we must have is that preparedness. Every labor room should have preparedness for managing shoulder dystocia cases. So the preparedness in the sense that shoulder dystocia drills must be taught to all the consultants, all the residents, all the sisters, staff, whoever is present. So every labor room should have this preparedness by doing the shoulder dystocia drills now and then. So that is the first and the important thing. Secondly, whenever such a patient is accounted, we must diagnose as early as possible. Like Deepa Madam has already discussed in details how to diagnose shoulder dystocia. So in a situation, if is encountered, this situation must be tackled by the senior most person who is present in the labor room. Or if that person is not present, then he should be immediately called wherever he is present. Otherwise, the person who is present must handle this situation, and immediately he should call for help. Whoever it is, he might call. See, junior consultant, maybe they are nursing staff, a midwife, or even if they're attendant, that person should call for immediately for help. Then pediatrician should be informed. Then anesthetist and OT team should be kept ready. And the attending obstetrician should not panic at all in such a situations. That is the first and important foremost thing. Then there are certain principles which has to be followed. Like we should never push from above. The fundal pressure is not warranted in these cases. In the alternatively, we can always use suprapubic pressure, right? So these are the few principles that has to be kept in mind.
Very nice. And like, when I think, of course, now I'm very well equipped. So God is kind. I'm not facing shoulder dystocia, but these are the mistakes I've done. And when we'll come by and by, we understand that the two external maneuvers are very, very successful. More than 80% of times, these two maneuvers of the external kind, macrobursts and suprapubic pressure, enough. So now I would like Dr. Moushami, so before you start doing anything else, I mean, before you do any maneuver, what would you like to do? Two important things.
Yeah, I would like to empty her bladder, give her a generous episiotomy, because episiotomy will in my vaginal maneuvering the means any manipulations are required, that will help. Episiotomy will help in that. Then after that,
call for help.
Call for help. Yeah.
So already we've been going through all these maneuvers. So I like Dr. Abha. Ma'am, will you like to tell us? Already it has been told, but I want to just add in, you all are working in big hospitals, but I'm in a standalone hospital. So for those like me, our nurses have to be told that what is macrobursts and how they have to be brought to the edge of the table. So Dr. Abha, please elaborate on these.
Yes, thank you, Dr. Mitra, and thank you, Dr. Lakshmi, for including me in this very important practical obstetric drill program. And so first, let's talk about the macrobursts maneuver. I think this is the first maneuver that has to be tried whenever there is shoulder dystocia. And I think about 80% of cases of shoulder dystocia, they are corrected by this. Actually, very nicely, Dr. Deepa has explained about the truck and the bridge. I think that is such a beautiful way of expressing that. So what we do in macrobursts is that we hyperflex the legs on the thighs. And for that, we need two nurses so as to hold the thighs. We don't leave them. Just ask the patient to do it. They just lift the legs, hyperflex them. And so the thighs, they come directly over the mother's abdomen. And then what happens? The buttock is lifted. The buttock is lifted. And as a result, though there is no actual increase in the diameter, but because of the flattening of the sacrum, there is an increase in the diameter. And along with that, the very important thing is we should not apply downward traction. We had the habit of the juniors putting downward traction. It's always the axial traction. That is, the traction has to be given along the fetal spine. This is very important. And in most of the cases, we are able to deliver the shoulder. The anterior shoulder comes out, it slips out. But sometimes the macroburt fails. And then what we do? We combine the macrobursts with the suprapubic pressure. Again, that has been so beautifully explained by Dr. Deepa, but just the position of hands and where to stand. We have to stand on the side of the fetal back. And as rightly said, the occiput guides us to the fetal back. And then the hands have to be positioned either in the CPR position or as a fist position. And the movement, it can be either a continuous movement or a rocking movement. But what is important that the movement should be downwards and laterally. That is, it should be towards the symphysis pubis. And Along with the suprapubic pressure, we have to again apply axial traction with the macroverse position. And if the arm slips, it's well and good. But if it does not, then this is the time that we have to go for internal maneuvers. For internal maneuvers, yes.
I will ask Dr. Mala or Dr. Vijay or someone else to take the internal maneuvers. And actually, we may put it in any order and as per the mnemonic. But the most important thing to remember is that the external maneuvers, if we are not able to do it, this is what Dr. Deepa has said. I wanted to show a video also, which is very nice, of Gaskin's all four, that gives you space in the sacral hollow, which is anterior. But can you tell us about these two rotation, the bringing down the posterior arm or the rotation of the shoulders? Dr. Vijay?
Yeah. As already explained, after the initial macrobot, and of course all the four we can do at any stage, but after that when we put a suprapubic pressure and it still doesn't come, then either some people are very comfortable going posteriorly and bringing out the posterior arm, but other, because that will also bring down the space needed for the shoulder to deliver. Otherwise we go on to the internal maneuvers, we will press the anterior shoulder slightly, and that will give a little bit of tilt as well as shorten the shoulder transacromial space, and that is how that will get released. And then we can also rotate, and that is why this is called as a corkscrew maneuver. Before this we say either external Rubin or internal Rubin or Rubin 1, Rubin 2. We can do the names, that's not important. What is important is the procedure, and when we do, we can rotate the entire baby, because the anterior shoulder, if it is already at a lower level, so when you bring it slightly, you put a pressure and then bring it posteriorly, it is going to get delivered, because it then goes at the lower level in the sacral hollow. So that is how it gets delivered. Of course, easier said than done. If it's a big baby, head is stuck, neck is stuck, by the time you manipulate all these things, it also looks quite chubby and the edematous, it is there, but then we will have to deliver, and that is how we are able to manage all that. And of course, these are all the procedures by which we very strongly hope that it should come out. And in case, but all the time we must remember that patient should not become panicky, we should not become panicky, and we have to apply. And after every procedure, we try again with a little bit of facial traction and then try to see whether we have succeeded. Otherwise, there is no point. And if all these fail only, then we have a little more extensive maneuvers. Should I continue or somebody will say, Mitra?
So I will just like to, you've done it beautifully.
One point, Dr. Mitra, just give me a minute.
Please.
Like this wood screw maneuver and Rubin 2 maneuver. When they were originally described, fundal pressure was combined with it. So now they have got away with these names, wood screw and Rubin 2. And along with this rotation of shoulders, I think we should combine it with suprapubic pressure.
Everything
and we should rotate the shoulder anteriorly.
Another thing is that there is a very interesting innovation, and there was a video about that also, that in the posterior shoulder, in the posterior axilla, this catheter is introduced, and that is passed through
axial traction. Axial traction.
No, not axial traction. That is for the ease of rotating the shoulder. They put a
sling and then rotate.
A sling, yeah. They put
sling,
a sling across
sling.
the axilla, and then they use the sling to rotate the posterior shoulder anterior. But these are, like, I think they come out because of some desperation. And yet we don't have a very robust, acknowledgement of this procedure. But yeah, it was interesting. It was there in the video. And this is the delivery of the posterior arm. And we has been very nicely told that there is more space posteriorly. And what we have to remember is, don't panic. Don't think that you have to just pull at the head and bring out the baby. We can try all these maneuvers and successfully bring down. So Dr. Mala, if all these things fail, what are the other options in those dire situations?
When all the options have failed, as you said, that we can bring the patient on all fours. That also increases the capacity of the sacrum, because the head tends to fall down And then we can have some space in the posterior part, and we can put our arms into the posterior hollow of the sacrum and try to bring out the posterior arm. Maybe it may be very cumbersome because we are not used to delivering the patients on all fours. The other option can be we can do clidotomy in the one of the methods, or we can do symphysiotomy. But all these are not easy method. Easy said than done. We are not used to it also.
I would like to ask the panelists, the experts, and the seniors. Anybody has any experience of a symphysiotomy or a spontaneous clidotomy? Sometimes when you're doing the manipulation, the clavicle just gives in and you suddenly find it comes out easy. Has anybody had a personal experience?
No, clavicular fracture, if spontaneously has happened, sometimes when you're compressing too much, definitely immediately baby will come out. That's true. But then, you know, better than the humerus fracture or Erb's palsy, because clavicle is going to heal very well in the only thing is baby will have pain when we are lifting or when the baby is lifting the hand. And then we do an X-ray because not only that we are suspecting, but even otherwise there is a crack which you can hear, and then baby suffers, and we have to definitely tell the patient, and it heals very well. Clavicle is
okay, so symphysiotomy, would anybody like to tell? Because this is a very simple procedure, and all you have to do is just infiltrate local and the fibrous tissue between the two pubic bones. That has to be just given a stab incision, and it opens up.
It's a soft symphysis.
Yeah, the problem is that you have to save the urethra with prior catheterization. So
just wanted to add here, Dr. Mitra, symphysiotomy. We really have to be, you know, one red rubber catheter always should be on our trolley. That you have to remember, because symphysiotomy once in your lifetime you may have to do. Okay. So it may be for this kind of patient where a shoulder dystocia happens, or maybe the aftercoming head of the breech. Okay, these are the two situations where you may need to do a symphysiotomy, and these are unpredictable situations. So when you have these kind of patients, you should. In fact, you should be in a habit to keep a red rubber catheter on your trolley. Why? So that you should be, when you want to do a symphysiotomy, first thing you have to save is the urethra, and you put the catheter, and it is in the center, and then you just with your fingers you take the urethra to one side, and then you will incise the symphysis pubis. Remember that you just have to incise the anterior fibers, not the posterior fibers. Don't cut through the symphysis pubis completely. You will just the anterior fibers, and the baby will create its own way, and little bit of the fibers of posterior will separate on their own way, and you don't have to cut through the posterior. So these are the simple tips and tricks.
And so actually it is very important.
There is no need, and then there is no need to suture. Okay. Nothing. Just strap it after the delivery has occurred. People used to, what they used to do, they used to strap the knees together also, but now the knees strapping is not required. Only that area, maybe rest for 24 to 48 hours is what is advisable, but not strapping the knees together. So these two things are important. And clidotomy, most of the time it requires courage. Let me tell you, these things require courage. It can even be done with the episiotomy Caesar, which is there. These quite stout Caesars are there. The clidotomy can be easily done. You should practice, if you really want to practice this, should be practiced on in an IUD. Okay, so what we tell our resident that you should practice on an IUD, because it's easy to do, but it requires courage.
So I think, thank you so much, Dr. Surekha, because obviously these things that we are mentioning at the end, fag end is that when we are really stuck up in shoulder dystocia and we have to bring out a live baby, so these things have to be in our mind.
It is better than doing a Zevanelli's maneuver, because Zevanelli's maneuver is not easy at all. Not easy at all. So doing a cleidotomy is much easier, and
Or a
only one-sided a single-sided cleidotomy is also going to suffice. So doing a Zavanelli is not at all, easy.
And with Zavanelli, it is not just the baby which is under problem because we have pulled it so much down and now we are pushing it back. It's also
Actually,
the
I do
uterus
not
and the
know.
lower cervix and everything which
Frankly
is going to
speaking,
give way.
I have seen a case
I have done
where somebody
so many lectures and so many cases on shoulder dystocia, and I think we should stop talking about something which we cannot and we have never done.
No, I know one incident, Dr. Mitra, where somebody tried and it ruptured the uterus.
Uterus
So it's not possible. So better do a cleidotomy. Okay,
Yeah.
if
Or a
required, do a
symphysiotomy.
symphysiotomy, but Zavanelli is
very,
not
very true.
possible.
I think
Not possible.
symphysiotomy is a choice, in an emergency.
Yeah.
Actually, yes, these are
it is
desperate
easy procedure.
last
Only
minute
thing is not
measures.
to go through and through. Yeah.
Yeah. So, okay, now we'll be just concluding this session with the do's for the medical legal safety, Dr. Vijay.
Yeah, it's very important. And the first thing is anyway, patient is going through, so you can talk to her. And also, of course, documentation when you are all stuck with the workup with the management of the shoulder dystocia. But remember, there has to be somebody who is at least noticing some things, either the timing, what happened, who came, what procedures were done, because detailed accounting of all these things, just like Dr. Deepa mentioned, it's very, very important to save yourself because you have done your best. Sometimes it goes unanticipated. All these things can be faced in the court of law, but if you have not documented, we all know no documentation, not done. So that means we cannot save our skin saying that we did our best. And of course, why sometimes we are anticipating, but sometimes we don't. And being true is very important, and never tell the patient, oh, you didn't push properly, that is why this happened. See, that doesn't save you. In fact, it makes her more defensive. So rather say, yes, certain times these things happen and we anticipate, we tell them. If we don't anticipate, doesn't mean that every delivery is going to end up into shoulder dystocia, and try to say in cases of high risk factors. In fact, one of my patients' first case was shoulder dystocia, but second one delivered very easily. But she was so scared, she kept on telling me, oh, I would want to have cesarean. Then I told her, if you're coming through easily, we are going to take up, and she delivered. So certain times you are very lucky, but definitely the high risk factors have to be kept in mind, and we need to do. And of course, all the injuries and all the traumatic things we have to explain properly, and we have to be with them holding their hands. That only will save their suing. And
so I just wanted, thank you, Dr. Vijay. You explained everything, but I just want to point out one thing to the audience, that let it not be the family which come back to you and say, iska haath nahi hil raha. So
exactly.
If we land up in that kind of complacency, or that will be really negligence actually,
you should be
for whatever reason. So a neonatologist should do a complete examination whenever there is delay in the second stage, little bit of difficulty also. Maybe only our few maneuvers have helped us deliver the baby, but the neonatologist must examine, and the family should not be telling you what has happened. Then you are going to be stuck. So that was my one thing that I thought I should add to that. And this is the documentation, but we don't have such elaborate systems. Yet I think if we mention that this is a big baby, these were the maneuvers done, this is the time of delivery, examination, these are the findings, and this is the necessary advice, and then talk to the family. And as already mentioned, and it is in the records, that if physiotherapy is started, most commonly it is not a palsy, it's a paresis. And like you would have seen in Dr. Mane's case and my case also, that the girl or the child has recovered fantastically well. So let's not put the guilt, and let me give it over to Dr. Surekha. Thank you, my panelists, the experts who made our job easy, and all four of you from the four corners, and Surekha. Thank you so much, and thank you, Lakshmi.
Thank you, Mitra.
So,
Thank you, Dr.
we have to only anticipate, prevent, and manage. My biggest lesson is do not panic and do everything as per this drill. And really, we can manage any difficult case, and teamwork and documentation.
Mitra Di, can I share? I'll share from my side.
I'll
share from my side.
Thank you.
Thank you very much. And that was an excellent discussion with the panelists. And let us now move on to the obstetric collapse. So, is my screen visible?
Yes.
So, obstetric collapse, as we have the maternal collapse, as we have heard from our speaker, is rare but serious. It's life-threatening. But let me tell you, it's not so rare also. If you're in a public health setup with so many deliveries happening, you are going to encounter a few cases of obstetric collapse, and you must have managed either in your residency or in your consultancy also. So though it is written here 14 to 60 per lakh births, I must say that we have encountered quite a few and we have managed. So diverse range of causes, and the survival of the mother as well as the baby depends on what kind of resuscitation you have done. Fetal survival, of course, depends on what maternal resuscitation you are done. Maternal survival depends on what's the etiology, what facilities are available, is your team trained, what is the expertise of those people who are on spot, and what are the kind of teams you are having. So now let me talk to you about this case scenario. This is not my own case, but it has happened. I was called to the spot after the things were over. So I do know firsthand what was this patient about. She was a primi gravida, 23-year-old, very, very young woman, came to the outpatient at 10:30 a.m. and she was a 37 weeker. She had mild pain in abdomen, for which she reported. She was a known case of preeclampsia on tablet labetalol since 1 month. Urine albumin was 3+, so she was labeled as severe preeclampsia in latent phase of labor. Now, she was also given injection Maxel because her diastolic blood pressure was above 110 diastolic. So she was started on Maxel drip. Now on the same day, so she came at 10:30 a.m. in the morning. She was not in labor, okay, but just mild, just 1 or 2 centimeter of dilatation was there till 6:30 p.m. What happened in the evening, she had a spontaneous rupture of membranes on her own. She was shifted to the labor room. A per-vaginal examination was done and the os was found to be 3 centimeters dilated. Now at 7:15 p.m., so within half an hour to 40 minutes, she started having bouts of continuous, vigorous coughing. Her pulse rate rose to 117, saturation started falling, mask was connected, but within minutes, the saturation fell from 84 to 77 to 68%, in spite of giving oxygen en masse 15 liters per minute. Now the patient was shifted at 7:35 p.m. to the surgical intensive care unit, which was nearby only. Physician and anesthetist were urgently called, and she was gasping with tachycardia, intubated. She was put on the ventilator, and patients were explained the condition in detail, and the written consent and everything was taken. The counseling of the relatives was done. However, she was on the ventilator. However, at 7:45, patient arrested. She pulse and blood pressure not recordable. All the resuscitation measures were started immediately. The multidisciplinary team was already there. In spite of the resuscitative measures, the patient could not be revived. This is the case. I was called on the scene after the things were over, actually, so I know firsthand what happened. So, Dr. Abha, I want to ask you, what went wrong, and was this preventable, according to you?
Well, what comes to my mind after listening to this case, that this patient, she was a case of severe preeclampsia. She came in latent phase of labor, but I think no decision was taken to augment the labor. I think if a patient with severe preeclampsia comes, I think delivering the fetus should be one of the aim of our management. So I think that decision was not taken at that time. The patient was in latent phase of labor and she was like that for around 8 hours, like from 10:30 to 6:30. And once she went into labor, the membranes ruptured and most probably she had an amniotic fluid embolism, because preeclampsia is a high risk factor for amniotic fluid embolism. and the patient, she started deteriorating. She went into a cardiovascular collapse. That is what I could understand from the case. So it could be a case of amniotic fluid embolism.
What do you think when see initial decision is fine that the decision was not taken? She may have augmented.
Now I'm coming to that.
That's fine. But once the collapse happened, what do you think?
Now I'm talking about that. Now, once the collapse occurred, again at that time also, we should have thought about the delivery of the fetus, because we all know that cardiopulmonary resuscitation in a pregnant woman is very difficult. All the causes were told, I think, by the previous speaker brilliantly. She told about the large breast, the difficulty in intubating the patient, and of course the position. There is pressure on the inferior vena cava, and therefore either we have to tilt the patient, but that is also not sufficient. We have to empty the uterus. Once we empty the uterus, the resuscitation can be done more effectively. And the other point is also that once the patient has gone into arrest, then also we do not continue the, we have to take a decision to do a perimortem C-section. And that is not only in the interest of the fetus, but also in the interest of the mother. Because once we do a perimortem C-section, there are chances that the fetus and the mother both can survive. And of course, when the abdomen is open, we can even go for an open cardiac massage. So I think better resuscitation, and I think this decision of perimortem cesarean section should have been taken. At least it could have given a chance for the mother to survive. That is what
definitely and absolutely to the point. I think the take-home message here is that when you encounter such kind of patient who is going into arrest, she hadn't arrested initially. Okay, but we do know that now she's deteriorating. The mu score is for that, the tachycardia, the respiratory rate rising, the falling oxygen saturation, all is indicating to us that the patient is now going towards an arrest. So if you have such kind of situation where the patient is arresting, so immediate resuscitation measure there and then only. So no shifting to the intensive care. You have a labor ward, everything should be available. The crash trolley, everything should be, of course it was available there. But I think the decision to evacuate the uterus, that is the one which needs, that is the one which needs the courage, maybe the experience. The person who is in charge then and there have to take the decision, and probably that was what was missing in this case, and the patient was not evacuated, and hence the resuscitative measures were not effective. And that's the message I think we should all be giving. Just let me ask our panelists, how many of you have done a perimortem cesarean section? I heard Dr. Mitra saying that she has, but do you see challenges when you yourself are part of a team or somebody else? Do you think there's some sort of a challenge in taking the decision for doing the perimortem cesarean section? Dr. Vijay Lakshmi.
Yeah, I think, no, I myself haven't done, but I have been in the surrounding when this was being done for one of them. But the thing is, yes, it is very, very difficult. Actually, it's very challenging to take that decision. And you have to really get onto your toes to be able to do that. And it's sometimes, although you are all at that time, probably you muster up the courage and do, but very difficult to take that decision. It's very emotional also. I mean, it's very tough that the mother is almost gone and then you just open up and take the baby out. But when the baby comes alive and something is spared, something is saved, it's a big victory, and probably
but
that is
Yeah, Dr. Vijay Lakshmi, let me tell you, and I think in the further discussions also, let us put into perspective that we are doing the perimortem cesarean section not for the baby, but
not for the
mother.
Baby.
Even if the baby is dead, even if there is no fetal heart.
No, as in fact, the video was also shown.
So that, I think if we can push that thing into the minds of the participants of this webinar, I think our goal would be successful for doing this 2.5 and 3 hours of marathon of webinar, which we are doing. So let's move ahead with that point in mind, that yes, perimortem cesarean section is the one which has to be done in a patient who has gone into an arrest. So Dr. Maushmi, do you think that these kind of cases can be identified early and how do you, any warning signs you can have for these patients?
Yes, ma'am. Whenever any obstetric patient enters our labor room, we always have to do the triaging of that patient, whether the patient is a high risk patient or a low risk patient. But if we do the triaging, but after that also we must remember that maternal collapse can occur in any patient without any prior warning. And the high risk conditions in which collapse can occur, as we all know, cases of hypertension, eclampsia, then anemia, rheumatic heart diseases, any other pulmonary disorders, then diabetes mellitus, any renal hepatic causes can lead to a maternal collapse. So these are the high-risk conditions, and we have to identify these women and have to have a special obstetric unit to manage these cases. Like we have at our center, like we have a high-risk unit and a low-risk unit. So we manage all the high-risk patients in another unit and low-risk patients in another unit. So
yeah, Dr. Maushmi, I am also from GMC Nagpur, and do know that there are two labor rooms. We have two labor rooms. One labor room is dedicated only to the high risk, and another labor room is dedicated to the low risk. But still, we have to remember that collapse can occur without warning also. We should have the MUSE, for modified early warning score system. We should be training ourselves and our residents and our staff, nurses. So these, I think if we can train that, yes, if there's a tachycardia, if there's a respiratory rate is rising, if the fall and saturation, so these the modified early warning system score system will tell us that this patient may land, and that is probably the clinical deterioration of the case. We have to be trained to recognize early and then intervene early so as to reduce the maternal morbidity. Dr. Mala, such kind of collapses occurred. What are the various things which come into your mind? What could the patient be, and how you systematically rule out things and come to you may not, the diagnosis may not be that important, but if it is certain things are there which you can taken care of, I think that's important to find out the differentials. Yeah, you're on mute, Dr. Mala. You have to unmute.
Basically, this patient may be having amniotic fluid embolism, which can occur suddenly even in a low risk patient. Then there are cases of pulmonary embolism. And of course, there are cases of hemorrhage, anaphylaxis, uterine inversion, which can also lead to maternal collapse. There can be cardiac reasons like arrhythmia, acute heart failure, or there can be eclampsia. This patient had severe high BP and they can throw fits. There can be cerebrovascular accidents as well as epilepsy. So intracranial hemorrhage also can occur due to severe high blood pressure, preeclampsia. We have to keep all these things in mind, and one by one we have to exclude them. Basically, first action is to resuscitate the patient, take care by ABCD. We have to take care of the airway.
That will come to in the later on. I just wanted to highlight this very beautiful diagram is available and on up to date also in RCOG also, that yes, this is a beautiful way you can remember intracranial hemorrhage. It could be eclampsia, it could be pulmonary embolism or amniotic fluid embolism. It could also be an anaphylaxis, any drug you have given, magnesium sulfate, even a local anesthetic. Some drug, I have seen collapse occurring just because of an antibiotic. So you have to remember what initial drug you have given. And of course, hemorrhage, it could be any sort of hemorrhage. It could be a uterine perforation. It could be a concealed or a revealed hemorrhage, or it could be a postpartum hemorrhage. It could even be a patient who had come to us in a trauma, some hepatic or splenic rupture, which is rare, of course, but we have to remember all these things in mind. It could be an aortic dissection, cardiac causes, or it could be a simple hypoglycemia, also a patient collapsing in front of you. So and of course, sepsis, septic abortions, we have seen quite a lot in our residency days. Now, though the prevalence has reduced, but the sepsis also is one of the causes where the patient can. What do you think are the
So Surekha, the easy mnemonic 4H4 T and E.
Yeah, I think we are going to go, Dr. Vijay Lakshmi will tell us about these treatable. Some causes are not treatable. Yeah.
I think definitely hypo or hyperkalemia, if we are able to get the blood test done, we will be able to control them. And potassium, for all reasons we know, high potassium, low potassium, both are very, very dangerous and we need to really have a look at it. And being in obstetrics doesn't mean that we don't know general medicine. We definitely know, and we need to really look into it. Hypoxia, of course, sudden hypoxia happens only when a pulmonary event happens, but that apart also, any oxygen pressures are important. Hypovolemia, again, maintaining the volume, IV fluid volumes are very important, which quite can get missed during the obstetric management, and all the thromboembolic episodes, and of course the anaphylaxis towards the toxins or towards a sudden tamponade can also happen. But we know that in this particular case that you mentioned, probably a severe hypertensive state, and then we don't know whether there was any kind of abruptio or any hemorrhage or any bleeding, and that alone would have even precipitated this particular event. And also amniotic fluid embolism, as Mala said, could be the probability, but then that is again a diagnosis of exclusion. So we have to really confirm it only later, if at all, through postmortem, in case the something happens to the mother. But if the mother survives, obviously it stays as a provisional diagnosis. And I don't think there is any particular diagnostic test to say that this thing, because we say it is an it's an anaphylactic reaction to the fetal cells or the amniotic fluid cells.
That we are going to come to, Dr. Vijay Lakshmi. Just wanted
So
to say
again,
that certain
all
things
these
are
causes-
treatable. Yeah, certain things
these
are
are all
treatable.
controllable,
Like said,
treatable. They have to be in the
hypovolemia.
mind.
Yeah, so these 4H, 4Ts and E, I think this is the mnemonic which will tell you that these are the treatable causes which you should look into, and side by side when you're doing the resuscitation, this should come into your mind. Does any of these are responsible for the collapse, then we can treat that patient. So Dr. Mala, this patient now needs resuscitation. What is so different in the CPR during pregnancy, and how does pregnancy impact our resuscitation, and how we should go about it?
Dr. Nutan already said that a pregnant woman, it's difficult to resuscitate. Pregnant women becomes hypoxic very readily. They become they are difficult to intubate because of the large breast. Sometimes they are obese, and the pulmonary function is already compromised due to the pregnancy. So we have to tilt the patient to the left lateral, either 15 to 30 degree, but take care that their chest is on a flat surface so that it is easier to resuscitate them. If the uterus is more than 20 weeks, we have to actually push the uterus towards the left, up and off, and then only we can release the aortocaval compression, and then we can resuscitate them. So these are the quite a few points that we have to remember when we are resuscitating a pregnant woman.
And that is why probably what we were talking of evacuating the uterus becomes important, because the external chest compressions are also not very effective. As you have rightly said, the patient is obese, the breasts are heavy, patient deteriorates very rapidly. The hypoxia, hypercapnia, acidosis also comes in very quickly. Even the intubation, I think, is quite sometimes
slight laryngeal edema. Laryngeal edema sets in pregnancy, and that makes the intubation a little difficult. Even
so that's why I think what happens depends on what kind of resuscitation you're doing. And this resuscitation, we sometimes think that it's not going to happen to me, So these kind of situations, we think it's not going to happen in my unit because I don't deal with very high risk. That sometimes our practitioners may be having this wrong notion, but everybody should remember, all obstetrics providers should remember that we all have to be CPR literate. Even the basic life support and the advanced life support, all of us should be very, very well versed with. So that's, I think, the basic
can become high risk.
Yeah.
In practice, so any low risk patient can become high risk. They can have
Dr. Vijay Lakshmi, can you tell us about the resuscitation guidelines and what is a little bit different what we used to do earlier, and we should be ready with that?
I think right nowadays we do have to go through, and we should train the newer younger generations into the basic BCLS and all those things right at the start. That's what we do in our hospital, that we make it compulsory for them to go through the course, because they must know. And what earlier we were using lidocaines and all they were using, but now again we have shifted to amiodarone 300 milligram IV, and that is what they say is works very well. In fact, I was watching the management which was mentioned by Dr. Nutan, but they have just written, but I think they are not using amiodarone. But vasopressin also is a good substitute for epinephrine, and that is what we have shifted to nowadays. And of course, whenever we are doing all these resuscitatory measures, it's very important to keep the, everybody known that we are trying our best, because we don't know at the end whether we are able to do that. The presence of defibrillator is again one important thing, whether we are running a one-man show in one this, or it is very, very life-saving, and defibrillators definitely come handy, and AEDs should be marked. And I'm sure most of the bigger hospitals, they do mark it, but we should be aware where these are being kept. And anticipatory treatment, fine. We don't anticipate cardiac arrest in every patient, but then in labor room, at least to the minimum till we are able to, and one code blue, or, in the hospital, in the labor room, there could be a code which we all should be aware what to press. We do have code blue, code green, code pink, and all those things. I think we should be aware of these things, and we should be able to get to the help. See, we keep trying, but at the same time, we should pull in the expert hands, and minimum basic things should always be available in the trolley. And we can also have one very good chart put in the labor room, because it's a teamwork, and everybody cannot be a master in the team. There should be one person who is really directing everyone to do. But at the same time, these large cannulas and all those things, I think we need to really...
Dr. Vijay Lakshmi just wanted to highlight the fact about the defibrillators. The big hospitals do have these defibrillators, but I'm not very sure whether single practitioner units have defibrillators in their hospitals. So let us remember now the international guidelines have this change, and now external emphasis is on defibrillator. So as
we have AED. We have AED.
Dr. Mitra, I know that, and I recommend, we suggest that all hospitals who are running a maternity unit should have a defibrillator, and just having it is not sufficient. You should be able to, use it when required. So train yourself again and again, update, train your team. And these are, as Dr. Vijay Lakshmi has said, these are the guidelines, and these are the resuscitation.
Because there is a small
Dr.
window when defibrillator will act.
Maushmi will tell us how to resuscitate.
Yes, ma'am. Whenever we do the resuscitation, we must follow the basic ABCDE approach of resuscitation. We must see for the vitals of the patient, whether the patient is having carotid pulse or not, whether she is breathing or not, whether she is responding to your oral commands or painful stimuli. In this situation, there will be two parts. In one patient who doesn't have any pulse, she is not breathing at all, and the other patient who is not breathing, but she has having her circulation is intact. Okay, so in such situations where the patient is not breathing but her circulation is intact, we just give her 100% oxygen, try to ventilate. If her spontaneous respiration doesn't come in 5-10 seconds, we immediately intubate the patient. And the second type of a patient is one who is, her carotid pulse is absolutely absent, she is not breathing at all, pulse is absent. In such a situation, you have to immediately go in for external cardiac massage, that is the CPR. So every obstetric person who is there in the labor room should be trained enough to do the external cardiac massage. So it is done in the tune that you have to give compressions, 30 compressions, cardiac compressions, in such a manner that the chest moves at least 4 centimeters downwards, and 2 breaths in a minute. So continuously you have to give this resuscitation, and also give adrenaline, and see whether the heart is appearing or not. You have to apply the ECG leads and see whether the heart is working or not. And if the heart comes, then it's well and good. If it doesn't come, then you have to take a decision within 3 to 4 minutes. If she is antenatal, still antenatal, then you have to decide whether you have to deliver her or not, and carry out the perimortem cesarean section, as already talked much about it. So this is in a way, and then you have to, after resuscitating, basic resuscitation, you have to go in for the means the cause. What is the cause of the maternal collapse? Then you have to treat accordingly. So if it is eclampsia.
Absolutely, Dr. Maushmi is very well.
Surekha, just one sentence. Earlier, we were always talking of ABC. Now the thing is reversed. It is now CAB. So compressions first, so that at least the heart, So compression, then airway, then breathing.
Yeah, first compressions and then 2 breaths in a minute. So in a 30 compressions and 2 breaths in a minute. That has to be remembered.
I think all of us should go and do the BCLS course and the ACLS course. That's the basic life saving and the advanced life saving. It's very, very important. Let us all emphasize that all of us should be well versed, even if whatever age you are, whatever may be your experience in practice, whatever single or multi-specialty, you should be well versed with the basic life saving. And emergency uterine evacuation, I think we all have to remember, it is not for the baby, it is for the mother. Even if the baby is already dead, it is the responsibility of the person who is there on spot. No anesthesia is required for that. You don't have to shift the patient to the OT and all. Incise the abdomen and the uterus in any way you want. You want to do a vertical, you want to do a transfer, doesn't matter. This all is required so that you can facilitate the cardiac compressions. And many a times it happens that once you have delivered the baby, the mother's heart will come back. So, and of course, if your mother starts responding to the resuscitation, then you may transfer the patient to the theater and you may achieve the hemostasis. But removing the baby immediately is very important. Dr. Abha, why do you think it is so very important to deliver the baby?
And as we talked, it is mainly of maternal interest. Like if we deliver the baby fast, like within 4 minutes of this cardiac arrest, it's also good for the baby because the baby gets oxygen and we may get a live fetus. But basically what we do, it is mainly for the maternal interest because the resuscitation will be more effective if we empty the uterus.
Yeah, and 4 to 6 minutes of time has
that
been
is mainly
suggested.
For the babies. That is mainly for the babies because oxygen supply will go to the brain of the fetus and we'll get a fetus, a live fetus or a neurologically intact fetus. Otherwise, there may be irreversible brain damage if it is deprived of oxygen for a long time.
Yeah, Dr. Abha, it's also for the mother as well as the babies.
As I said earlier, that we can do the CPR more effectively. And also we can do it's open, we can do an open cardiac compression also. These are the 2 points that I would.
And as soon as you remove the baby, the aortic cable compressor is taken off, the venous rate return increases, the cardiac output increases, ventilation is improved, functional residual volume is improved, the oxygenation is improved, oxygen consumption is reduced, carbon dioxide production is reduced, so hypercapnia is not there, and improved maternal and newborn survival, as we have seen in the case series, which was demonstrated very nicely by our first speaker, that yes, just by doing the perimotor C-section, we can save 50% of the patient. So it's very important that decision is taken and so that you can improve the survival of the mother as well as the baby. So your decision, immediate CPR, ACLS, early intubation, left uterine displacement, start the C-section within 4 minutes, deliver by 5 minutes. That's how it should be. And it has to be, imbibed everybody that yes, if required, if such kind of arrest is there, you should do the perimortem C-section without.
Sureka,
so let me show you this.
Can I add one thing before you start the video? I want to say one thing, that the biggest problem with the obstetricians is that the minute some emergency happens, we go on the defensive. So half of our options don't come in. So that is why it is very important to reiterate that think of the perimortem cesarean, and at the end of the day, we can always complete our documentation. So we're very afraid that we are going to lose the mother, lose the baby, and they will be doubly on our head.
Life-saving situations like this, consent is not required. That's very important to remember also, because you shouldn't waste time. You should go ahead. The person who is on spot should be the one. So I'm just going to show you a video which has been shot in Lady Hardinge Medical College.
Preparations should start from before. Like we should not wait for the patient to go into cardiac arrest and then start the preparations. for a small settings, or for, you have to have that in your mind from before. Like if the patient is deteriorating fast, you can
everything is in the mind, Dr. Abha.
anticipate.
You rightly said. Rightly said. Everything is the mind. Is in the mind. The
And
decisions have to
anticipating.
come. And let me, Dr. Sheila, just let me go through this video, and I'll come back to you. Yeah.
हाँ जी मैडम, हाँ 5 मिनट बाद मैडम, 5 मिनट बाद निकलिए। अच्छा ठीक है, तो हम आते हैं। तो थोड़ा सा बस लास्ट में खत्म हो रहा है। हाँ 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 2 मिनट, हाँ जी 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 मैडम, बस 5 मिनट।
Yeah, so I think Dr. Sheila wanted to say something here. So, Madam, for your comments.
Very nice discussion, Surekha, I must say that the experience speaks a lot. I just wanted to share that we had a case of, in last 3 months, we had 2 cases of pulmonary edema coming, okay, with pulmonary edema. And the code blue was initiated and the anesthetist came running and immediately intubated, and luckily the FHS was still there. Okay, she recovered fast, and we could really settle her, and then I took her to OT and did a section. But that was real miracle. But the another case who came with a pulmonary edema again, by the time she was intubated, you know, like she collapsed. So then and we lost her. Then the debriefing was done. When we did the debriefing and the discussion, so the anesthetist, when he came to the labor room, he asked for nitroglycerin. Then there was no nitroglycerin, and nitroglycerin is the drug for pulmonary edema. Okay, then when we had the debriefing, I asked him, do you have it in OT? He said, no. I said, see, it is not there in operation theater. How do you expect me to have it in labor room? But if you say that it is the drug which could have saved her, because nitroglycerin reduces the preload, reduces the afterload, and with hypertension, with pulmonary edema, it is the LVF. So then we did the local purchase on the same day, and now it is kept in the labor room as well as in the OT. But you know, when we did the debriefing and the discussions, and when we had to write the summary, all these things. So I just wanted to convey this message that nitroglycerin.
That's very nice that you have brought into it, because many a times, you know, the practitioners will ask us what all should be there in the labor room. And so, Dr. Mala, we're coming to that point now. What do you advise the equipment and what should be there in the labor room to deal with such kind of situations?
Labor room is a high risk area. We should have our equipments to intubate the patient. We should have automated external defibrillator with us, so that if in case there is any cardiac arrest, we can act immediately. Of course, our labor room should have all the equipments for emergency cesarean sections, because normally in our labor room across the corridor, we have OR for emergency cesarean section. And there we have Boyle's trolley, everything for intubation as well as for emergency section at any time, 24/7. And of course, when we have Boyle's trolley, we have everything in there. For difficult intubation, we have fibro-optic laryngoscope, we have...
Yeah, Dr. Mala, what we're talking of is a single practitioner who is working on her own. What all she should have in her labor room? Not of her. You know, in an institute, we'll have everything.
Yeah, she should have instruments for immediate intubation.
Intubation, that's important.
Yes. Automated external defibrillator she should have. They should have laryngoscope. They should have thoracotomy instruments. They should have blood warmer, rapid fluid infuser, and of course, equipments for central line as well as arterial line equipment.
So these are the minimum, I think, which are recommended. And your cardiac arrest trolley, defibrillator, this is very, very important.
Very important.
You should anticipate that a pregnant woman may need a difficult intubation, and this all should be. So you should not be running around for these things when the time comes. That is the message, I think, which is very important. So many times, you know, what happens, the obstetrician is in a denial. And that's why there is a delay. So she is in the problem is being denied. This has not happened. That's what she thinks. And there's the delay, communication errors, not prepared, inadequate response, and specialists not there, airway problems, cardiac problems. So these are the problems which actually lead to the bad outcome in these. And that's why I think we have to work on these things. And that's why we come to the next question. Very briefly, can you talk about all this, you know, the protocol and the workforce which is required and the team which should be there, Dr. Vijayalakshmi?
Yeah, again, it will depend on the size of the hospital or your practice center. See, if you are saying a one person running, she cannot be running around with everything, because it's again teamwork. And that means if she will have to, in due course of time, delegate and teach and train people who will come handy at that time as well. Even the ANMs, even the nurses, even the ward boys, if they are trained well, they are not going to insert the laryngoscope or they are not going to insert the IV lines, but at least they will get things done and then, call for help, and all those things can be done. So it's very important, depending on the size of the hospital or the center that you are in, to see that things are being done in order. More importantly, all the time we have everything, but sometimes, you just do everything in haste and you lose track of things, where they are and what is happening. So that kind of jumbling should not happen. And every day this has to be an exercise to recheck that things are being replenished, things are there. Sometimes the labels are there, but things are not there inside. Sometimes trolleys are there, they are not equipped fully. And once they are used, they are not got back. I think that is where the disorder goes on. And when there is a multimodal specialty hospital, obviously things are much easier. But at the same time, when we have, because obstetrics runs on smaller units also many a times, and then though we are slightly moving away from those things, but in many places, I think it is still there, and we definitely need to have a lot of coordinated work and delegated work, and then we need to know that things are in place.
Thank you, Dr. Vijayalakshmi. I think the take-home message is that even if you're a single practitioner, you should identify people. You should have a network ready where in one phone call, patient should be the specialist, the help should be available to you within 5 minutes. That kind of network you should prepare. Your team, of course, has to be very well trained, but people should be coming in to help you within 5-7 minutes. They should be there. Your anesthetist, a physician, these are the people who are going to help you. So that is again a multidisciplinary approach. Your logistics, if there is a hemorrhage,
So Rika, I just wanted to say two important things. Like whatever the video which Dr. Newton had showed, when the box is being brought, it is written on top, please replenish the contents. So this is very important, as Dr. Vijay said, that everything should be updated. Second thing is, a very common mistake which happens in smaller hospitals is that the doctor is ordering for injections and the relatives are given a parchi.
That should never happen.
That should never be done. No parchi should be in the hand of the patients or attendants. With the flap and the noise and the rush,
if something untowards happen, this is the thing which will go against you, that the doctor didn't have the resuscitative drugs, were not there in her hospital.
Our own staff should go and get it. You should not be shouting at your staff, because in panic they will be even more nervous. So when you have
all this,
staff,
Dr. Mitra will come only with the drills. Only with the drills. If you keep on doing regular drills, that is going to come, that the peace, the calm, and the professionalism, that is going to come only with drills. And of course, the hemorrhage protocol logistics also should be there, because many times our patient collapses because of hemorrhage. So that the protocol should be well in place, and you should be, so I'm not going to talk about that, but yes, this should be there. The resuscitation, the hypotension, the shock, also you should be able to manage very, very quickly. So let's come to the fag end of our webinar. And in just a brief, I would like to know how to diagnose this patient. She was of amniotic fluid embolism, probably. Dr. Abha, what do you think? What are the indicators which tell us, yes, this patient was of amniotic fluid embolism? Is there any criteria? Is there, or do you think that it is a diagnosis of exclusion? Dr. Abha is not there.
No.
So if you can take Dr. Vijay Lakshmi briefly, I would like to know.
As I said, very briefly, because we have discussed it earlier. Yes, as I said, it's a diagnosis of exclusion, and only when you say that other hemorrhage and all those 4H and 4T and all those things cross your mind and you don't see anything happening, then probably you think it has come, and it comes like a shock. Nobody can predict that some patient can go in for amniotic fluid embolism. Nobody can come to a full diagnosis unless we are able to really find those amniotic squames or amniotic cells or fetal cells in the maternal blood. And the only thing possible is
that is not important also. I think when a patient is in
the only thing is the cardiac event which has happened, and then the pulmonary event which sets in so fast. In this particular patient, for example, the SpO2 came down so fast. So either a pulmonary edema has set in or a pulmonary embolism has set in, and the cause could be the amniotic fluid embolism. Always amniotic fluid embolism is there in the mind, but because we are not really labeling them, because there is no positive thing right when the patient is there that you can say that this is an amniotic fluid embolism. And even sometimes they have confused it with the aortic dissecting aneurysm of aorta once was confused with this. So all these things can happen. So amniotic fluid embolism again is a very, very good, suspicious diagnosis.
There are these criteria which I'm splashing on the screen presently, but I think we are not going to wait for those criteria and all, and we definitely want to start the management immediately. Maushmi, what do you think? Can you just brief us about this management which we can go about in amniotic fluid embolism?
Yes, ma'am. This is a very tricky situation. The patient, when the patient presents, the patient is in hypoxia and hypotension. That is the first, these are the first two things that we have to treat. So for hypoxia, 100% oxygen with positive pressure ventilation, the patient will need ventilator. So that intubation is the must in this case. Then secondly is the treatment of hypovolemia. The patient should be resuscitated with the 2 large bore needles IV fluids, crystalloids, and colloids. And in these patients mostly requires blood and the blood products, because by that time the DIC is already set in because of the anaphylactic reaction of the amniotic fluid. So along with treatment of hypovolemia, these patients also require inotropes support, right? Noradrenaline drip for hypovolemia. So that is the basic and the resuscitation of these patients.
Yeah, so yeah, definitely you have the the oxygenation, the circulation, and if the patient is going into hemorrhage, the coagulopathy, these are the three things you have to manage in an amniotic fluid embolism, and you have to have a set protocol, and you have to train your team to manage a patient of maternal collapse. So at the end, what we can come to a conclusion, and we can take the take-home message is that if you want to improve the outcome of maternal collapse, you have to be ready. Your team has to be ready. You have to have a staff which knows what to do if such kind of thing happens. Emergency equipment should be assembled and should be ready for use. Systems should be in place. Drills should have been practiced earlier, so that if something like this happens, you do not panic. Be forewarned. That means you should have a system to, find out which patients may land into such kind of things. You need an early warning system, a scoring system. You should be trained to pick up. Your staff should be picked up, and after such event, of course, you have to review, you have to debrief, you have to revise, and that is what probably is going to improve their outcomes. So this is very, very important that your team has to be trained, and an outcome to be successful. You have to have communication, preparedness, multidisciplinary team approach, and a set protocol in your hospital to manage these things. So with that, we come to an end, and the experts can comment and on the panel. Dr.
Surekha, I just wanted to recount, because that slide looked very busy, but the cardinal 4 things to be always present for amniotic fluid embolism. It's a clinical diagnosis, but cardiorespiratory compromise, DIC, and the event should be within 30 minutes of any laboring event. So like if it is 6 hours, 8 hours later, and we write our diagnosis amniotic fluid embolism, we will be making a,
should either be during labor or within 30 minutes. That's the criteria.
And the last thing is, there should be absence of fever
and pulmonary.
There should be no fever. So to label a patient, actually the point is this, कि मेरा reason ये है कि standalone में जब आपके साथ ऐसा होता है, तो आपकी जो clinical diagnosis आप अपने documents में लिखते हो, they should, be closer to your actual diagnosis. So that is why I said that these 4 cardinal things are very important before we put down that query amniotic fluid embolism. And these days, after COVID, a lot of patients are having myocarditis and cardiomyopathy. So let us not forget, I think whenever we are dealing with such sudden cardiac collapse, we should put a query cardiomyopathy. So, I mean, and very important, you've taken it beautifully, but some learning points is in post-op period, if there is desaturation and tachycardia, this is very, very ominous. I have lost a patient post-delivery. Everything was fine. Her pain abdomen was there. I bothered Surekha a lot with that patient, and she had tachypnea, unexplained pain abdomen, and not even very strong tachycardia, just okay. I shifted her to a higher center, and yet we lost the patient. And the only ominous thing was tachypnea and ongoing acidosis. So hypoxia is something which is very dreadful in pregnant ladies.
We'd like Dr. Nutan to comment, please.
Yeah, thank you, Surekha. Lovely.
Thank you. Dr. Nutan, you're on mute.
I'm trying to unmute myself. Thank you for such an excellent webinar. So do you want to just say vote of thanks?
Any comments you want, you think are important that we should emphasize?
So firstly, I want to thank the audience because, their active participation. I was looking through the chats and all. I think they were interacting and that made me quite happy. Thank you for all the panelists to be there and, your expert. And actually what made me even happier is that we are, all talking from the same hymn sheet. So there wasn't anything that, I would say, actually, we don't do like this in UK or, so I was happy that, we are talking universal language. And so that made me really proud and very happy as well that, the message is going on. And we are, as we say in English, we are talking from the same hymn sheet or, singing Aarti from the same sort of writing, as we say. So no,
Dr. Deepa is
experience. And I think my only thing was, which we've touched on, and actually that, as I was saying, we are all talking the same thing. But, as you touched upon, preparedness, your drills and your documentation are the three important things that, we can never have enough of. So I don't know if Deepa was going to...
if Dr. Deepa wants to say, otherwise say something.
Dr. Deepa is in.
Yeah, please go ahead.
And thank you, Deepa, for stepping in the last minute.
It was a really interesting discussion and I'm really glad to have been part of it. Thank you all.
So over to the MOC.
Thank you, ma'am. Thank you, ma'am, for wonderful panel discussion. It is a very practical panel discussion, and I think every gynecologist should be aware of what should be done at such situations, and we all should know the resuscitation part, because we are always dependent upon our staff or our anesthetist or our intensivist that he would come and he will help us. Actually, we should know how to intubate the patient and what are the practical drills if the patient is in shock or in any hemorrhage, or if the saturation is falling, when to intubate, how to intubate. These are the practical tips which we all should know, actually. And at the end, it's I want to give official vote of thanks.
Just Nutan, you would like to give some concluding remarks on the whole webinar? Nutan, your concluding remarks, then vote of thanks.
No, I mean, I've already done it, but it was an enjoyable experience, I'm sure, for me and Deepa as well. So
thank you. So nice of you, Nutan. Yeah, Sushma.
So we are very proud to be.
It's a great pleasure for me to be a part of such a wonderful webinar with such senior and eminent faculties. It has been a wonderful presentation packed with the knowledge, and whole credit goes to our esteemed faculties. On behalf of whole team of Indo International Web Series in association with RCOG License Group, I would like to extend my sincere thanks to Dr. Lakshmi Shikhande ma'am, Dr. Jyoti Malik ma'am, Dr. Josna Pundir for putting lots of efforts in organizing such a webinar. And from bottom of my heart, I would like to thank Dr. Nutan Mishra ma'am and Dr. Deepa Nair ma'am from UK for their elaborate talk on evidence-based approach in the management of maternal collapse and shoulder dystocia. Then I would like to thank our eminent moderators for the panel, Dr. Surekha Tade ma'am and Dr. Mitra Saxena ma'am, and esteemed panelists, Dr. Mala Srivastava ma'am, Dr. Vijay Lakshmi Sheshadri ma'am, Dr. Abha Rani Singh ma'am, and Dr. Mosmi Tedes ma'am for giving us deep insight on the topic and making the panel discussion very interesting and useful. And now I would like to thank our chairperson, Dr. Jayam Kanan ma'am, Dr. Supriya Jaiswal, Dr. Sheila Mane ma'am, Dr. Varsha Baste ma'am for chairing the session and sharing the interesting facts with us. And at last but not the least, I extend my gratitude to Dr. Jyoti Malik ma'am for conducting the webinar smoothly and putting enormous efforts in making this webinar a huge success. And lastly, I thank Dr. Lakshmi Shikhande ma'am, Dr. Josna and Dr. Jyoti Malik ma'am for giving me this opportunity to be a part of such a esteemed platform. Thank you so much, ma'am. Thank you.
Thank you, for conducting the whole webinar. Thank you, dear friends. See you soon on some other platform.
Very, very useful webinar. I think it was attended and everyone is benefited with this webinar.
Is it recorded?
Yes.
Yes, ma'am,
we
it
will
is
send
It
the
is
link.
recorded.
If you can share the link.
Yeah. We will put in the group.
Because shoulder dystocia and all this will be very helpful to postgraduates as
Yes.
well. Not only postgraduates.
Everyone.
Even for us also, ma'am, because
for
we are
everybody.
not doing the things
You can
nowadays.
stop the recording, Firoz.
Yes, ma'am. Sure. I'll
Recording
share.
भी stop कर दो, YouTube live भी stop कर दो.
Thank you to Walter Bushnell.
Thank you all of you. Thank you so much.
Thank you, ma'am. Thank you.
Nutan,
I have an emergency, so I have to leave. Thank you.
Thank you.